Okay, so well, I think we are good to start, and we have more participants than before. So, well, I will start with an introduction, and then we'll go around all this journey about the breast cancer diagnosis and imaging. Let me show my screen. So, well, hello everyone, and welcome to this training, the 11th of April training from this imaging diagnosis in breast cancer, the present and the future. I'm Anton Aubanell, and I will be guiding all this training since this morning at 9 till when it ends around 5 p.m. So it's quite a busy day today. But well, I wish this is quite interesting for all of you. I think most of all the staff in the hospital is working in this. So we'll cross the fingers that everything works properly. So, well, we'll start this first part of the day by talking a little bit about what are we going to do during this day, and who are we, what is this project, and everything. And well, this is a little bit how the day is going to proceed, and I'm going to go a little bit around this. We are here 9 a.m. coffee time, so I'm giving this introduction. Then Dr. Miranda is going to talk a little bit about the breast cancer. That's what we are going to be talking about all day long. So all imaging techniques and all the diagnostic techniques that we will be talking and we will be speaking about in this training are based and centered and go around the breast cancer. Then the head of department, Dr. Rodríguez, will talk about the screening program in breast cancer and, well, how does it work in the hospital and in our country. Then we have a small break, and after that, we'll go on give a brief presentation of all the diagnostic techniques that we have and how we use them and all that, so that you all know. Then have a brief introduction of what we will be talking about deeply in the rest of the training and the rest of the session. After that, I think one of the most interesting talks of the day, I give it myself, but is the BIRADS system talk that will allow us to know how we grade the imaging findings, how we grade the lesions, how we know if something is good, if something is bad, how we should proceed in a finding. So this is going to be very useful to understand all the rest of the techniques, because it's used in all the diagnostic of the breast cancer. Then we have a small speech about the mammography with and without contrast, which it's the mammography. It's a very common technique. It's used in all the centers, but nowadays we have this contrast mammography that we can use, and it's not that extended, so it gives a lot of information very fast, and it's very reliable, you will see. And we have some works done here in the hospital that show really promising findings about the mammography with contrast, which will be showing, and you will see how the image is and I think it's very beautiful. Then we will talk about the breast ultrasound, and well, I think this is an interesting speech, not only because I think it's one of the most beautiful techniques we use in the breast cancer diagnosis, but also because well, the QUSTom project, as we will talk a little bit in this introduction, because well, we're giving it, it's based in the ultrasound. So I think knowing the basis and how the lesions are seen and how we proceed and how we grade them is going to be quite nice and interesting. Then we'll talk about the breast MRI and this technique that's one of the top technique used today for breast cancer. It's very long, takes a long time and a lot of machinery, and it's quite difficult to have access to it, but makes a big change in the diagnosis and the treatment of breast cancer. Then we will have a break for lunch that I think is well deserved after all these hours and hours of talking and training. Then we'll have for the end, we have already seen all the techniques, and then we'll have a small rip-off of this. Then first we will talk about the multidisciplinary of the breast radiologist. That's we'll focus on the different techniques and also on the different professionals who work in the committees in deciding how we treat patients, how we treat this pathology, and how we proceed. And I think this is a very nice view of how a hospital works and how you think should be done and must be done. Like I think this is just for like a small pill before starting. This is the only cancer that must pass through a committee, all the cases. So this is going to be interesting, I think. Then Dr. Moraru will talk about the interventional radiology in breast imaging. And I think, well, you will see all the diagnoses that we've seen through imaging. We will see all the possibilities that we have in performing procedures to have the anatomopathological proof, to have the anatomopathology, to know which cancer are we looking at, which molecular findings we have in that cancer, or to rule out cancer. I think this is going to be very interesting. And also we can do treatment in the interventional radiology and like curative treatments. So this is going to be quite interesting to go a step forward. And then Dr. Igo will talk about the artificial intelligence in breast imaging and where we are and what is being done nowadays. This is going to be at 4 p.m., so quite late in the day, but I think it's going to be a nice talk. And I think this plan covers more or less everything about the diagnosis. So those of you who stick around it all day will know quite a lot about this and have a clear picture of how the breast cancer is diagnosed nowadays in the hospital and how we treat it and how, and more or less how to interpret everything. Well, Dr. Miranda is coming for the next talk. We'll go around here very soon. We've been talking. Here's Dr. Miranda. A little bit about, I finish this and then about the breast cancer, as I've said. And well, I'm gonna talk a little bit about this training, who we are and what is this project, the QUSTom project, and well, who we are in this hospital performing all this training today. Well, the QUSTom project is it stands for Quantitative Ultrasound Stochastic Tomography, and it's a European project, a Pathfinder European project, that aims to develop a new imaging technique to diagnose breast cancer based on ultrasound and 3D ultrasound, and to be able to characterize and have a better detection of this pathology. These are all the partners included in the program. And well, I'm going to talk a little bit about us, the ones organizing this training today. We are the by the Brown Breast Women's Pathology or Imaging Unit, and we are here in this part of the hospital. This is the Brown Hospital, and this is us here. Well, this is one of our machines, and this is the boss, Dr. Rodríguez, who will be giving some of the talks today. And well, this is a unit that performs breast imaging and also all women's imaging, also pelvic and all kinds of cervical and everything related with cancer and women's health. And we'll talk a little bit about what we have in our hospital, we have the mammography. We are going to be talking about ultrasound. This is our machine that we have in here, and this is also we will talk about MRI, which we already seen in the presentation. As I said, this project is it's Pathfinder founded project, and well, this is a little bit about the project. This is the QUSTom like the 3D ultrasound machine that we hope someday we can have in our hospitals and help women to have a better diagnosis of the breast cancer. This machine is it's this kind of recipient where you can put the breast and has like lots and lots of ultrasounds that can get a very clear image of the breast in a 3-dimensional. So there is no influence of the hand or who is performing the test and that. And you can not only receive like qualitative data of the breast, that's what we are having today in the ultrasound, we will be seeing later on this day, but we also have quantitative information of how the lesion looked like, what's the consistency and all that. So we hope that in the future, this is a reality. This is how it looks like today. And well, this is something that's being developed between all these partners in the KIT. They developed the machine, and also the Barcelona Supercomputer Center, the Vera College, the actor, everyone is developing also the software to be able to detect the lesions and to be able to characterize these lesions in the breast. This is a little bit how it works. When we have a lesion inside the breast or inside the recipient or inside the machine, there's a wave that arrives there, and it has a shadow, it has another wave that it's received by other detectors, and that allows us to have a clearer image of the lesion and all the breast. So we hope this is a good start for this presentation. This is going to be a look in the future. That's what we said in the name of the training. So well, after this, I leave you with Dr. Miranda.
Good morning to everyone. Well, my English is not as good as Dr. Aubanell is. That's because I'm a bit older than he. Anyway, first of all, I want to congratulate my colleague, Dr. Aubanell, because he has worked a lot for this training. And I'm sure that without him, this training wouldn't have worked. So thank you very much, Anton. My aim is to give you a little introduction to breast cancer. As you probably know, breast cancer is the most common cancer in the female population. 1 in 8 women will develop a breast cancer during her life. But also breast cancer is the most common cancer overall. Breast cancer is the second cause of death in females after cardiovascular diseases. And the median age range of diagnosis of breast cancer for women is from 60 to 70 years old, with a median age at 63. So that's why breast cancer is so sensitive in our society. Okay, there are different types of breast cancer, and they can be classified based on the type of cells that are affected. The most common one is called invasive ductal carcinoma or non-special type carcinoma, which starts in the cells that line the ducts that carry meal from the breast to the nipple. And we talk about invasive carcinoma when the cells that grow into the duct broke the wall of the duct and spread to the stroma, to the breast stroma. That's why we call it invasive carcinoma. Breast cancer may cause a variety of symptoms, but not all women with breast cancer experience symptoms, and not all these symptoms can, or not these symptoms are exclusive of breast cancer. These symptoms can be caused also for or due to other disorders. But the main symptoms, or the most common symptoms, are a lump in the breast or in the armpit that can be a lymph node, a nipple discharge other than breast milk, and especially blood, dimpling or retraction of breast skin, pain in any area of the breast or in the nipple, retraction of the nipple, redness or flaky skin in the nipple area or the breast, any change in the size or the shape of breast, and thickening or swelling of part of the breast. So these are the most common symptoms that we can find in a patient with breast cancer. About the relative survival rates, well, relative survival rates are used or meant we can use it to estimate the percentage of people who are alive, people with cancer who are alive after a period of time, compared to the expected survival rate of people without cancer. Okay. Obviously, breast cancer survival rates vary depending on the stage of cancer at the time of diagnosis. And here you can see the 5-year relative survival rates for breast cancer based on the stage at diagnosis. So you can see that when a breast cancer is localized, so it doesn't spread. It is not on the lymph node, in the lymph nodes. So lymph nodes are not affected. The survival rate is very, very high. It's about 99%. The second stage is when breast cancer spreads to lymph nodes. So we call it regional spread. And in this case, survival rate is still high, about 85%. And the last stage is when the cancer spread to other systems. We call it distant metastasis. So when we find metastasis at the diagnosis, the survival rate comes down a lot, and we can see that survival rates in this case is about 29%. So that's why an early diagnosis is very, very important. There are several risk factors for breast cancer. Some of them are modifiable, while others are not. And the most important risk factors are the age, of course. The risk of breast cancer increases as a woman gets older. Gender, obviously. Family history, especially in first degree, as a mother or sister. The existence of gene mutations. such as BRCA1, 2, etc. A personal history of breast cancer. Women who have been affected of, or women who have had breast cancer are at risk of developing a new cancer, and that's why in some cases we treat, depending on the type of the tumor, we treat patients with an hormonal blockade after surgery. Dense breast tissue, we are going to talk about dense breast tissue later. Alcohol and obesity. And be careful with obesity, because obesity is a real risk factor after menopause. But there are some studies that have concluded that obesity can be a protective factor for breast cancer before menopause. Okay, and it doesn't mean that women should be obese. Okay, but in obese women pre-menopause, before menopause, obesity can be a protective factor. Okay, at this point, I would like to introduce a little how we approach the study of a woman with symptoms or not of breast cancer. For breast cancer diagnosis, we can separate patients or women in three groups. The first one are asymptomatic patients from the screening program. In Spain, the screening programs is for women aged from 50 to 79 every 2 years, but according to the European guidelines, we should perform a screening mammogram to all women aged from 55 to 74 years old once every 2 years. We should add a complementary test, mainly an ultrasound, in patients with dense breast. Okay. The second group are patients or are symptomatic patients or patients with an abnormal findings. In this group, we will perform all the necessary tests that we need to confirm or rule out a breast cancer, such as mammography or tomosynthesis, ultrasound, magnetic resonance, contrast, mammography, etc. And the last group are patients at high risk of breast cancer, patients with a gene mutation. And in these patients, we will perform a mammography and magnetic resonance once a year. And what about dense breast tissue? Okay, why is so important dense breast tissue? Because dense breast tissue can decrease mammogram sensitivity up to 40%, increasing false negative. And I don't know if the video is going to work. No, it doesn't work. So in this picture, I show you a frog. The frog is hidden by the bark of the tree. And imagine that this frog is our tumor, and the bark of the tree is the breast tissue. In this case, a very dense breast tissue. So the bark can, or the frog can be hidden by the dark. And the tumor, the frog is our tumor, can be hidden by the dense breast tissue. But also density is an independent risk factor of breast cancer. About 4 to 6 women with dense breast tissue have 4 to 6 times more risk to develop a breast cancer than of general population. So density is a very dense breast tissue is very, very important for us, or to us, in the study of women with symptoms or not. And what does dense breast tissue means? As you probably know, we can classify it mammograms into 4 groups according to the American College of Radiology, A, B, C, and D. And we talk about dense breast tissue in C and D type. And this is the prevalence in the general population of the breast density. So as you can see, in about 50% of women who undergo a screening mammogram, we should add a complementary test, mainly an ultrasound. And what about the treatment for breast cancer? Okay, treatment of breast cancer depends on several factors. The most common treatments that we can offer are surgery, radiation therapy, chemotherapy, hormone therapy, targeted therapy, immunotherapy, etc. But normally, treatment plans may involve a combination of this therapy. And when why we start with surgery, or when we start with surgery or chemotherapy or hormone therapy, well, basically depending on 2 factors. The first one is the immunohistochemistry type. Immunohistochemistry tumor type, and it's a bit difficult now to explain what is a immunohistochemistry type, but basically is to know if our tumor is hormonal sensitive or not, or if the tumor expresses a protein called HER2, etc. And the second factor for selecting or for choosing the treatment for breast cancer is the cancer staging and the diagnosis. We use for cancer staging, we use the TNM system. That T means tumor size, N means lymph node status, and M means the existence or not of metastasis. And there are other factors to select or to choose treatment for breast cancer, such as the age of the patient's overall, but etc. But the main factors are as I said, the immunohistochemistry type and cancer staging. And that's all.
Hi, hello everyone. After this small break, it's 10 time that should start the next talk of this training. And well, we have online here Ana Rodríguez, the head of the Women's Imaging Department here in Brightburn, and she will talk about the screening program breast cancer screening program. So I think she's online whenever. Second, Anna. And second, I go to search for her on second.
Okay, I think that's it. Let me check. Now you can hear me, and I think the sound is okay. Yeah.
Yeah, it's okay.
Okay, let's start then. Well, first of all, thank you for being here. This is a really nice opportunity to share with you some knowledge about breast imaging and about what we do related with breast diseases. This first slide is to give you an idea how the breast cancer unit from Hospital Valle is do the following diagnostic and sometimes treatment. Yeah. Oh. Okay. Well, Hospital Valle, this is our data from 2019. We are a breast cancer center. That means we do only breast diagnostic, follow-up, and treatment of breast cancer. And we have all the techniques. We have mammography, contrast enhanced mammography, ultrasound, MRI. We do any kind of interventional procedure like fine needle aspiration, peritoneal biopsy, vacuum-assisted biopsy, and it could be guided by the stereotactic system, the ultrasound system, or the MRI system. And we also do percutaneous treatment like excision of benign nodules, and also we are starting clinical trials treating with the guidance of ultrasound small breast cancers. That important data here. We treat more or less between 600 and 700 cancers cases per year, and more or less 500 of them are diagnosed by the one-stop clinic pathway. This is important because I want to show you we do all the diagnostic and follow-up and treatment of breast cancer, but we are also a screening center. We do more or less 20,000 mammograms per year, and we have a great, more or less a fifth of the Barcelona screening program. And that's very important because here in Spain, there are different programs in different communities and different hospitals, but it's important to understand that we do screening and clinic at the same scenario with the same specialist, and we work in a multidisciplinary breast cancer unit. Okay, that's my introduction. So let me change. Okay, this is just to show you our cases during the COVID pandemic, and you can see we, as second biggest hospital in Spain and the biggest in Barcelona, and in Catalonia, we had a lot of cases, and this is important to remember because the screening program and the clinical assessment was affected, but these external problems as COVID was, and it's important to manage all these ideas and understand what means populational or screening program dedicated to all the population. Started with our main issues today. We are going to talk about what means a screening program, the role of the breast radiologist in the screening program, what we need to have to do a really good screening program, quality criteria, and future ideas related with screening program. You know that breast cancer is the most frequent cancer in women in Europe. More or less 1 of 8 women in the European community will have a cancer before the 85 years. And the breast cancer is the first cause of mortality in women in the world. This is very nice. This is from 1992, is the first paper published related with our screening program. We started the screening program in 1989, and we know that the screening program reduced mortality related with breast cancer thanks to the diagnosis of small and easy to treat breast cancer. And we know that also the screening program is regulated in the European guidelines, and we have a lot of work with the European Commission and the EUSOMA and the EUSOBI and all the scientific societies working together to improve the screening program in Europe following the same direction. You know that more or less of 1,000 of women that are regular participants in the screening program, well, 50 of them will be suspicious of cancer in any of the calls, and 4 women will have a cancer. But those 4 women will have a very successful treatment and will be cured of the breast cancer, and just 1 case will be not detected by the screening program. That means the balance at the end is beneficial. We have benefits and harms in the screening programs. The benefit mainly are related with the early diagnose, early detection, and it will be more easy to offer a conserving therapy and less axillary surgery, and will lead a very good results at the end. And the harms are related with the false positive, of course, and those false positive will cause unnecessary biopsies and anxiety and stress, and will impact in the quality of life of the population. Of course, the radiation dose is an issue, but nowadays the equipment are so developed in that way that we don't give a significant radiation dose if we follow, of course, the European guidelines. And of course, the screening program as a population program will need many quality control, and it will be related with the screening itself, with a physical technical test, imaging quality test, of course, the breast positioning. Breast positioning is very crucial because we need to see all the breasts to be able to diagnose the cancer. That means we need to do quality control to the radiographer. We need to evaluate, of course, the radiologist's performance. And there's some organizational issues that we need to solve, like invitation, time between mammography and results, and time between the positive recall and additional investigation. Of course, the diagnostic procedure will be managed in the clinical pathway. Once we have a positive case, the case will be follow the one-stop clinic pathway. And of course, the treatment will be offered in the breast cancer unit with all the performance and high quality of the breast cancer unit. The screening indicators are something that we have to know and we have to apply in our screening program. Of course, the participation rate, the recall rate, the cancer detection rate are the main general parameters that we have to report and we have to know and we have to follow the European guidelines. The positive predictive value is very important because that means we will reduce the false positive and increasing the benefits of the program and reduce, of course, the harms. The lymph node status is very important to know when are you and what kind of cancer are you picking up, and types of surgery. That's an indirect indicator of your state of your cancers. Interval cancer, of course, is critical, and it means those cancers that are will be detected between the 2 rounds of the screening. Those interval cancers are an indicator of the cases that you are not able to diagnose. This is an example how the Catalan screening program is reported in Barcelona. We have different areas of the screening, and these different areas or different neighborhoods are included in the program BIRADS, followed by different the different programs in Barcelona. We are more or less the 1/5 of the population are followed by our screening program. Most of them are over the 5 round of screening. And this is an example how we check our result. This is the different neighborhoods, and one of them will belong to any screening in Barcelona. And we have the different hospitals. We are here, Hospital Vallebron. Those are data from 2018, and you can see, for example, our followed by the population is very high, it's almost 70%, and we have a really high, a really low recall is around 8 of recall. That's very good, and the detection cancer rate is still is also in the performance that are recommended for the European guidelines. So you know the screening is considered for some part of the specialists as not necessary anymore as it used to be. Does mean not the same program is good for all the population, but there's many studies related with that, and the European guidelines recommend to still do the program between the 50 and the 70s. But it's necessary to think that the new recommendations include the woman between the 45 and 50 and the 70 and 75. That means nowadays the screening program is recommended every 2 years for the woman between the 45 and the 75 years old. It could be, it is recommended every 2 years. It's recommended with mammogram or tomosynthesis. The double lecture is recommended with a judgment or a consent, and then the tomo is recommended in dense breast, and the way to call the woman will be by letter, or the new recommendations of course include the new technology by WhatsApp message or SMS message. It's important to consider that the consent form is a way to improve the addition of the woman to the program, and the strategy will be direct to special population or women with some kind of issues to attend the program. The program will oblige to create a special strategy to those populations. And about the paper of the breast radiologists in the screening program, well, it's very important that the reader could be the first or the second reader, and it could be a judge for the disagreement, or it could be a consensus between the two readers. It's important that the breast radiology know what quality control means, and the radiologist will participate in the quality control evaluation of the quality of the mammogram and the quality of their lectures. And it's important to have a quality control in the interval carcinomas. And also the radiologists will be part of the clinical assessment of the recalls, and especially in our unit, the same team works with the breast cancer cases coming from the referrals or coming from the screening program. As I said before, all the cancers will be attended by the one-stop clinic pathway or rapid circuit. And of course, the radiologists and of course the radiographers will need training and evaluation to assure the high performance of the lectures and the mammograms. Well, the requirement for the lecture and the equipment that the breast radiologists need include, of course, a workstation with the recommendations of the European guidelines. Of course, we have a hanging protocol to read, and we have a hanging protocol pre-formed in our workstation. That means we have a system where that we all the mammograms belonging to the woman will be on our workstation. So we have at least 3 rounds before the actual mammogram that's allowed us in an automatic and in a very fast way to compare the actual mammogram with the previous one. That's very important. That's improve the positive predictive value of your lecture. And we need to have a quality control assessment and feedback sessions to recognize our failures or our weak the weak aspect or the weak part of our lecture. Some readers are more specific, less sensitive, less sensitivity and best specificity, or the other way. That means we need to know what kind of reader are we, and we need to have that feedback from our quality control evaluations. And we are part of the team that, as I said before, do the clinical assessment of the positive cases. And of course, we need to have evaluation, and we need to follow all the guidelines related with the we need to have that continuous evaluation to allow our positive predictive value and reduce our false positives. This is an example of, this is my workstation. You can see we have here in the right, we have the report system. We report the lecture in an easy way, just clicking the result in every breast, and we have our mammogram hanging protocol that is, as I said, we can compare with the previous mammogram. And this is an example of a CAD system that we use to help the youngest readers to the quality control evaluation and to assure a good lecture in the youngest readers. Thus, the marks that the system gives you when you are reading, it could be before your first assessment or after your first assessment. It will be managed as you want. And of course, all these tools are necessary to improve our lecture, because with the number of reading that we do in a day, all these tools of automatic diagnostic assessment are used nowadays. And the requirements of a specialist breast center, is important to know that the centers that are doing mammogram for the screening program needs to have some specifications. For example, a breast center, the radiologists who are reading breast mammograms from the screening program need to be at least 30% of his working time in breast imaging. So we can't, the radiologists that are not related at least 30% in the clinical diagnostic pathway are not the same performance, or have not the same performance as the general radiologists. And of course, they will be involved in the clinical pathway and symptomatic breast problems as a part of a multidisciplinary team. This is very important. The number of mammograms that the radiologists who are working in a screening program is at least 1,000 if are related with clinical cases, but 5,000 if are working in a screening program. And of course, the breast radiologists must attend at least one diagnostic clinic per week for symptomatic patients. But as I said, most of, or at least Vallebrón and the big hospitals have in Catalonia and of course in Spain, the breast cancer unit are related with the clinical pathway. And of course, the training of the staff is very important. Is the number of reading, the evaluation, the feedback, all these items that we spoke are very important to maintain the indicators, and the recommendations in the European guidelines are the same that I tell before, the double reading, and that double reading improves the circumstances. And of course, the guideline recommend the research related with the screening, not just the indicator, also rule out different clinical trials related with the screening program are, of course, an improvement of quality in those programs. The evaluation, the number of reading, the quality indicator are something that we are used to do. Thus, every 6 months for the reading parameters, are every 4 months for the quality of the mammogram, are something that we have also every year to the feedback to the radiologists and the feedback to the radiographers allowed to maintain the performance of the reading. And this is an example how we do the assessment. We have all this data. It's not my intention to show data, but it's the way that we used to see our feedback with the positive predictive values, sensitivity, specificity, cancer detection rate, recall rate, and disagreement between the different readers. And we have this kind of graphics to make us understand the performance of the different readers, and the feedback is necessary to allow you improve your lecture if you are very sensitive, or you have better specificity. This kind of graphic lead us to improve our lecture. And of course, we can we can change the readers and make some couples of readers that are equilibrate the data between sensibility, specificity, and improve the positive predictive value of the lecture. We have a protocol of lecture, and these graphics show us the different BIRADS that we give to the lecture, and with this follow-up we can notice if we are doing less or we are having a high rate of false positive, and we can improve our lecture being having this kind of feedback. And this is just to show you the different graphic that we give to the radiographers to make them understand if the mammogram or the positioning is good of good enough, or if they have to improve, for example, including the pectoral muscles at least in a third of the mammogram, or leaving the nipple outside the retroareolar area, or including the external, the internal the fatty part of posterior part of the breast. All these indicators will help the radiographers to improve the positioning of the breast during the mammogram. And this is an example of why it's so important the positioning of the breast, because this is an example of a case that you can see the MLO projection. You know, we do 2 MLO mediolateral oblique projection are a craniocaudal projection, those 2, 1 for each breast. And in this case, you can see this Moraru speculated mass in the posterior and superior part of the left breast wasn't well spotted, and that the consequence of that bad positioning doesn't help to diagnose this breast cancer in the posterior area of the left breast. And this is another example of a bad positioning. In this case, in 2013, you can see the nipple was projected over the retroareolar area, and in 2015 it wasn't well positioning, and you can see in 2015 the MRI show us a bad definition, a bad defined mass, speculated mass in the retroareolar area of the left breast, and it was a breast cancer that wasn't diagnosed in 2013 because of the bad positioning of the breast. And this is another case in the craniocaudal projection. You see that this is the white part of the mammogram is the fibroglandular tissue, and the dark part is the fatty tissue, and you can see here that the fat posterior fat of the fibroglandular tissue wasn't included. That means we cut the breast tissue here, and we couldn't see the mass in the posterior and external part of the left breast, and it was a cancer that we miss in this mammogram because of the bad positioning. And what about well, this is just to show you how the COVID changed our numbers during the lockdown. Of course, the cancer wasn't, the screening program wasn't ruled out as usual because of the obvious reasons. And the conclusion of that was that we miss 20% of the breast cancer diagnosis, and we did more than a half. We had more than a half of the reduction in the in the mammograms during 2020. Okay, that's just to show you how the complicated it is to rule out the screening program with those big numbers and all the structure that screening program needs to offer. Every 2 years a mammogram to all the population between the 45 and the 75 years old. And we know that the screening program started in the early 90s. We started in 1989, but most of the screening program from Spain and are from the early 19s. And we still roll the screening that way. We are doing every 2 years for the women between 50 and 70, because still not here, at least in Catalonia, between the 45 and 75, we are doing 50 to 70, and we are doing the same. So the knowledge and all the scientific evaluation of the screening programs around Europe and America let us know that the same program is not the best for all the patients, or in that case, all the women, because we are talking about general population, healthy women. So we need to think that there's other ways there are other ways to do the screening and the early diagnosis in breast cancer. And this slide is a way to show you that we need to include different aspects, different we need to learn that the patient or the woman are not the same. So we need to include breast density, family history, personal history. We need to know what happened with the high-risk populations and carriers of gene mutations. We need to include, of course, the lifestyle factors, that body weight, physical activity. And we need to include data as the history of benign biopsy, because of many cases, those benign, not malignant, but proliferative changes in the breast will tell us that there's something going on there, and probably that woman will develop a cancer with more early or more frequent that a woman without a proliferative changes in her breast. And of course, the blood markers, SNPs, mutations are knowledge that we know are very important in the stratification on the creation of different risk groups. So we need to understand that there's some groups of women that will be in a high risk or intermediate risk or average risk, and we need to focus the screening and the test in different groups and in different complexity, of course. So the density is something that we already know, and we know that the mammogram this is the different A, B, C, D density patterns, and is related with the amount of fibroglandular tissue. When we have a fatty breast or a heterogeneous fatty breast, the possibility of diagnosed breast cancer here is higher because the mammogram is better. We can see better the new nodules or new microcalcifications or new distortions, different patterns related with cancer will be easier to see it when the breast is fatty. And of course, when we have high density, the white dots, that's the way that the cancer start, or microcalcification or distortion will be harder to see it when we have a dense breast. So we need to think that probably the screening program will need different technique. We are just using mammogram and in some cases tomosynthesis, but we need to understand what happened with the recalls if we need to apply different techniques in the recalls, or of course during the clinical path we do that we use all our tools to pick up the cancers and to find multicentricity, multifocality, but with the screening program, we need to understand if it's necessary, for example, to add an ultrasound when we have a dense breast, or if it's better not to do a mammogram in a very dense breast, and maybe it's better to do an MRI every 2 years, as some papers show us in the last 3 or 4 years. And that's why we have many trials ongoing. We have different trials in Europe and in the United States trying to understand if it's better just to continue with the same mammogram every 2 years, or if it's better to start using different techniques with different period, different time every 2 years or 3 years, depending on the breast density, family history, benign diseases, and all the conditioning that we are telling. And that's why we have a lot of studies in trying to understand which is the best way to do the screening program. This is just one of the initiative ambition, and this is very interesting because this group of work are now working with the European guidelines, and probably we will need a certification in Europe to be considered a center allowed to do or to roll out the screening program. And I think this is very important because, of course, if you have this quality control, the results of the screening program and the indicators will be improved massively. And of course, the AI is something that we already know that is not a future, is the present in the screening program. We have groups here in Spain working with AI and doing clinical trials in patients with patients in the screening program with dense breast. And we have some also results in other European countries, and we know that the AI will be very useful, not just to pick up, to detect cancer. It will be very useful to make our work easy. Our daily practice will be improved massively with the AI, because it's between 6 and 8 cancers in 1,000 of lectures. That means we have more or less 70% of the lecture will be normal, and that 70% will be probably well read by the AI. So we probably will need to focus the experience of the readers in those 30% of the cases that have probably a high probability to have a cancer. And this is an example. I showed you this slide before, and it's just to know how we do our reading, and imagine we can read more or less 100 or between 100 and 120 cases per day. So that means the AI will be really useful. And this is just to finish my lecture and let you know that the screening is something that is changing every day. The classical idea of the screening program is something that it need to change. And the AI will be very useful, and the different period of lecture, the different tools that we will be used, let's allow to improve our lecture, to reduce our interval cancer, and to help the radiologists and the radiographers with the mammogram technique, improve the parameters of the screening program, and we will see what going to happen in the next 5 or the next 5 years will be very different as we used to see the screening program 10 or 15 years ago. And I think it's 20 minutes to 11, so I think we have now time for comments or questions. I have Dr. Aubanell help me with the presentation, so if there's any comments or questions, Dr. Aubanell.
Yes. If someone has a question or something, can write it in the chat or just open your mic or whatever.
Okay, let me see.
And if not, we'll have a break now of like until 11 or something like that. So no one.
Okay.
So if it's okay for all of you, we'll have a small break until 11. Let's make 11:05 or 10, so everyone can have this half-hour rest. I'm talking later, so then I'm sure we can arrange the time so we can, everyone can rest a little bit. So thank you all, and we see each other in half an hour. And I think we can restart our training or little talk. Wish everyone has had time for a small break at the bathroom, grabbing a coffee, whatever. The next two talks I'm going to give them are about the diagnostic techniques and the BIRADS system, which I think Dr. Rodríguez already talked a little bit about that. I mean, mammogram and obviously, but we'll go deeper there. So I think, as I said, that BIRADS, it's a little bit more like a core thing in the breast diagnosis, and it's how we rate everything and we decide all treatments and all patients and what to do with everyone. So I think this is going to be quite nice. And then at 12, we have a recorded talk because Dr. Orlando wasn't able to be here, but she's going to talk about the mammography and the contrast enhanced mammography. And well, we'll go on from there. And with the breast ultrasound, as I said, and the breast MRI, this is going to be a talk given by the Dr. Vera, who will talk about breast MRI. So, well, now you have an hour with me. So, with you all, good luck with that. Okay, let's start with the diagnostic technique system. I'm sharing my screen. 1 second. Okay, wish everyone can see this. Is it, can you see my screen? I wish so.
Yes, we can.
Okay, perfect. So, well, we have these two talks together because I think they are quite similar and one will be the other. Something that you will see during this training is that in breast pathology and in radiology, but in breast pathology is a special case. We tend to study lesions with different techniques at the same time. So when something is not clear, we do another test. I mean, we can do a breast ultrasound and then do an MRI to be sure what we're seeing and what's the dimensions and what's the good treatment we can do with that patient, and so on. I mean, we can do a mammography, and if we don't see it, just right now in this break, we were seeing a case that we were not sure about that in the mammogram. So now we are Dr. Rose is performing the ultrasound to this patient. So it's not something exclusive. I mean, we can combine all of them. But well, after this small introduction, let's go to it and let's get started. as always, I always put this in the beginning, so we all remember that we're talking about breast cancer, and it's this one of the most widely spread pathologies, cancers in the general population, I mean, in women. And well, Dr. Miranda already talked to you about that. So this talk, we are going to talk a brief introduction, then we will go in more detail about these different techniques. We'll talk about the mammography, the ultrasonography, and the MRI, and then we'll stick with new techniques that are emerging. And after that, we'll talk about the BIRADS system and the grading system in breast cancer. So I think this is like gonna be a core thing. And there are some tests, and you will see that it's not that easy. I mean, also in the breast ultrasound, we'll have some tests at the end, so you can feel how it's like to do a breast diagnosis. So well, it's going to be a little bit fun. And so this is like from the beginning what we know, what we need to do the diagnosis, to reach a treatment, to be able to give patient options, or to say, hey, there's no problem there. So what we need is to know when we are seeing a lesion, how big that is. I mean, this is something we're going to talk about. The tumor size it's very important to know what's the treatment, what's the staging of the patient. It's different to have a 15mm lesion than a 4cm lesion. It changes the grading of the lesion, it changes the treatment, it changes the options, it changes what kind of surgery we can do, it changes everything. So when we perform an imaging, we must be sure that we know exactly how big this is. And there's something that Stefania is going to address, and you will see the importance of that, and also how important it is to have the right technique and to be sure that your technique, you're seeing everything. So I think that what we are seeing is what's really in there. We are not missing anything, because if we see a lesion that's like, let's say this is we're seeing it and say, hey, it's 15mm, and the truth is it's 30, and we don't stage this patient, the prognosis is worse. So we must know how big, what other structures are involved, if it touches the skin of the patient, if it touches a muscle, if it touches a bone, it's important. Then the lymphatic nodes, we will be talking about that, I think, in the afternoon, in the multidisciplinary talk, when we will talk a little bit more about the staging, and you will see why the lymph nodes are very important. But if the lymph nodes are affected, you upstage the patient, so you have a worse prognosis, and you need a stronger treatment, or maybe systemic treatment like chemotherapy. And we have to know also if there's illness, if there's cancer somewhere else in the body, for example, metastasis, when we talk about metastatic disease. So we can combine all these techniques that we'll talk about to know, to solve these questions, and also to be able to assess correctly each lesion. So with these techniques, when we see the lesion, we can also get some tissue. And this is something that's the interventional radiology. Some of these techniques allow us to do it. All of these techniques allow us to do it in different ways, like mammogram. We can do guided biopsies when there's calcium. You will see the importance of calcium. We'll talk about that now. And we can do also biopsies in breast ultrasound and MRI, and there's a beautiful talk in the afternoon by Dr. Moraru about that. And then it's very important to get some tissue of the lesion. The tissue is key, because while we don't have tissue, while we don't know what's really this lesion, we cannot put a name on it. We cannot say it's cancer. Even if the image is 100% looks like a cancer, we cannot say it. And even if the image looks 100% benign, we cannot say 100% until we don't have the tissue in our hands and we can analyze it, say, oh yeah, it's good, it's bad, which receptors does it have, what's the treatment in this lesion. So all these techniques allow us not only to acquire images, also to get some tissue. It's very important to know that what we are willing to do is to get a final diagnosis as accurately as possible. So well, let's start. This is the mammogram, one that we have here next door from us. where mammographies are performed on a daily basis. This is the one we are using for the screening program that Dr. Rodríguez just talked about. And well, you can see a little bit here. You can see this is the typical mammogram, and this is where the patient goes, and we put the breast in this recipient here, and it acquires the image from up to down. And there's a technician in the other part protected by a glass that's radiation proof, and it's acquiring the images and it's seeing it in real time, so we can know that the image is good quality. It's enough to assess the pathology, because if not, we have to repeat. It's better to repeat a test than the patient has to come some other day for another test. So the quality control, as Dr. Rodríguez said just right now, it's a key thing. It's a key issue in the screening program and in all the mammography and breast imaging. So let's see, yeah, this is the technique used in the mammography. As you can see, the image is quite from up down, so it's like an X-ray, a normal X-ray, but with compression of the breast in later days, like in later years or something like that. Before all this compression arrived, it was just without compression, but the quality was not that good. The mammogram has this image that you can see here. I think we have it bigger. Yeah, this is how we are looking for, and this is key. Like, how do we see cancer in a mammogram? Cancer, it's seen as a white dot in a dark sea, for example, like that. You can see this is the cancer. It's a very clear lesion. You can see it's a nodule here with the speculated. We will talk about all this in the BIRADS, don't worry, but of the descriptors we use. But you can see it's different from all the rest of the breast tissue. This is a very, very good breast to be able to see cancer in mammography. And you will see why I say that. Remember that the cancer is just a white dot in a dark background. So what are the good parts of the mammography? First, it's very fast. I mean, to do all the technique, it's just some minutes, like since the patient arrives in the clinic and gets the tests done, we do the compression, we put it safely and everything. It's around 15 minutes to do all the procedure until the patient is out. So it's quite fast. So it's very good for screening programs that all the population has to go through this test. It's widely available, any hospital or even in the primary care units, you can have one of these mammograms, acquire images so that it's close to the patient. The patient does not have to go to a third level hospital, which is far, and no, it can go next to their house, their home, and it's quite available. That's also good for the screening program. That's why we use this for the screening program. Then something else that's very important, we can see calcium with this test, and this is core to this presentation. X-rays are very good for assessing calcium. Some lesions and some kinds of cancer are just the only imaging that we can see of them, it's calcium. It's little dots of calcium, you will see them, and in the breast lesion. So if we cannot see it, we cannot see calcium. If you cannot see calcium, we cannot see this cancer. And for example, the ultrasound is very bad at seeing calcium. We need calcium to be very big and very thick to be able to assess it. In this case, you can see micro calcifications, which are very, very small, smaller than a millimeter. So this is very, very important. So if you need a good technique for diagnosis and for screening, you need to be able to see calcium. Then after that, this is a good technique also because we can perform contrast enhanced studies like contrast enhanced mammogram and all that, which allows us not only to see the lesion, to see if there are other lesions, how it looks like, if there's multicentrality, and assess the diameter of this lesion. We are currently conducting a study here in the body comparing mammogram with contrast against MRI, which uses contrast, and the results are very, very good. I mean, they're quite similar, and this is an excellent news for all of us because it's more widely available, the mammogram, than the MRI. So if this happens to be true, then more patients will benefit from that. Then it's a very good technique for the follow-up because it's very stable. So you can do an imaging and then compare it to another image acquired 6 months later or 1 year later, and you will have all this nice follow-up of the patient and see, oh, this looks like tumor, but how it was like 6 months ago, it was not there. It's more probable cancer, but if it was there, not that sure. You know, cancer tends to grow. So if it's stable during the time, it rules out cancer. Then it allows us to do also interventional procedures. You put a needle in this machine and it goes, you can guide it to the lesion inside the breast. Emma is going to talk about this in the afternoon, and well, I leave it to her. The bad part of this is first we use radiation. So we are suggest that we're using to all the population, all the feminine population at some point in their life. So we're giving radiation to everyone. And that's something we as doctors and as radiologists don't really like. We always follow a principle that's called ALARA, which is as low as reasonably allowed or possible. That's we need to reduce the radiation as low as we can for the safety of the patients. So that's a downturn of the mammography, absolutely. Also, there's a false negative rate, which I think Dr. Rodríguez just talked about in the last part of this training. But we will see some examples now, and you will see how difficult is that. And it's less. This false negative is more typical in the dense breath, the type C and type D that we will show, which is right. And it's also uncomfortable. To get a good image, you need a good compression of the breast, and this means 80 newtons of pressure, which is like a bottle of water just over the breast, and it's terribly, and it can be very, very displeasant for the patient. So some people say it hurts, it's not comfortable, and well, you have to stay there long time in a situation that you are worried about. Maybe you have cancer, maybe you are very nervous. So this compression, it's not pleasant. So it is also a downturn for mammography. That's very important because most of the patients will have a negative result. That's why. This is what we talk about when we say that this downturn in dense breast. So we have 4 breasts here, 4 mammograms. You can see all of them are in obliqual acquisition. You know, here you can see here the pectoral muscle. And they are nothing like that. Like one is very different from the other. And you can see the first and the second images are very dark. I mean, you can see here, it's everything, it's dark and just a small white part here. And as we progress to the D, this is called dense breast with the D, which is super white. What's the problem? I mean, let's go back to the part where we were seeing cancer. This is cancer, so it's white dot, a dark background. So it's perfect to see it here. It's very easy to see here. And in here, it's very difficult because the background is already white. So we are searching for white over white. This is super, super difficult. Even in the C, and this one in the middle, it's super difficult to assess if there's cancer. Let's make like, now we will show some examples, but let's look at this. For example, this part here, this is speculated. Is this a lesion or is it just normal tissue? It makes me like doubt, or maybe this part over here in the superior part. I mean, maybe that's a lesion. We don't know. It tends to be white, so this may be fat or a kyst or something like that. So as this. But as you can see, the first 2 pictures are much more suited for diagnosis in mammogram than the other 2. This is what we call dense breast. And in here, the mammogram has a higher percentage of false negative. And false negative are the worst. We don't like false negative because when we have a false negative, means that this patient, we say, hey, there's no problem, you can go back home, come back in 2 years. And if there was a lesion, imagine we say to this breast in the middle, hey, you have nothing, and this thing here was a cancer. In 2 years, it's going to be a very, very bad. This is a stage 1 cancer probably, and in 4 years you can have a stage 3, stage 4, and the treatment options and the prognosis is very bad. That's why we say that fake negative, false negative are what we don't want in the breast screening program. We prefer more fake positives. Like, I mean, you say, oh, you may have a lesion, come back and we make another test and we get sure that's nothing or that's something, than saying you have nothing, come back in 2 years, because that's very bad. That's one of the main limitations of the mammogram, to assess cancer in these 2 cases, dense breasts. So this is an image. Most of these images come from the literature, because I mean, for how you say, privacy purposes, we cannot show images from our patients, and I think the examples are already clear. It's what I was saying. This is type A breast. You can see it's fatty, all it's fat, and there's a lesion here. It's screaming, I'm a lesion, just look at me. You can see, I mean, but in the other breast, this is a dense breast, probably a type D breast. This part here is a tumor. I mean, you can say because there is a beautiful round circle there, but most times it doesn't look like that in real clinic. So maybe in this case, we would have missed that lesion. Maybe this not, because it's quite big. This is a 20-25 millimeter lesion, so be careful with that, but it's not that easy to assess. So this is a dense breast with a cancer that could be easily missed as a fake negative. That's the downturn of the mammogram, the biggest from my point of view. And there's something else that's already, I think, Dr. Rodríguez addressed that in her speech, that we have mammogram, but we can also have tomography with tomosynthesis. Tomosynthesis is like a kind of CT scan, but with the breast. And instead of just acquiring one image like this, for example, it's just one X-ray, we acquire multiple images. Dr. Orlando will talk about this in the next presentation. It will be super clear for all of you. But just for you to see here, this is the same breasts. I mean, those in the, I mean, both all are the same. And you can see this, first, the ones that have an M are the ones made by a mammogram, and the T is the tomosynthesis. You are not sure if there is something in here. Maybe in the upper quadrant, you can see, in the external quadrant, you can see something here, but you're not sure. But when we have a tomosynthesis, so you have more images and more definition, you can see this lesion quite good. You can see this is a tumor, this is another. I mean, it's speculated borders, it looks invasive, it's dense, it's seen 2 projections here and here, and you can say this is pathological. In here, you would say maybe this is some kind of tissue around there. We should do an ultrasound and we should do another test and come back and we test it another day and see how it evolves. But in the tomosynthesis, it's a better way to assess dubious lesions. I mean, as you can see here, there's less gland. I mean, you can see here all this white tissue disappears. So it's less glandular and it's more definition. It's a very good way to reduce fake negatives. That's what we are looking for all the time. You can see here I point the nodular tissue and the lesion. Then we'll talk about the ultrasound machine, the ultrasound technique. Well, the ultrasound is a way of diagnosis, a diagnosis technique that uses waves to acquire images, to perform images. And we will talk about this also in the ultrasound part, where we more about the physics and all that. in the later part of this talk at 12:30, something like that. And now just a small introduction. It's a high frequency acoustic waves produced by the piezoelectric crystal. And when they impact with the tissue, they come back, and then we can have this image. It's just like a radar, and this is what we use in breast imaging. This is called a linear ultrasound, which has a higher frequency than the other kinds, like we use, like the ones used in, for example, in pregnant woman evaluation, which is called convex, because it's not linear, it's a convex form, the ultrasound. And also we have lots of different types, the ones just intracavitarian, but this is the one we use in breast and also in musculoskeletal, because it has a higher frequency and a better definition. And what's all about, we don't need a huge penetration, we don't need the wave to go 30 centimeters into the body to assess the liver or to look at the aortic valve. We need to assess subcutaneous tissue, and this is the best we can have. So the good part of the ultrasonography is that it's a very fast technique. I mean, relatively fast. It's a little bit slower than the mammogram, but it's faster than the MRI. And you can go look at something. It's very dynamic. Also, I would say dynamic more than fast. But yes, it's quite easy to perform. Then also there is no radiation. We use sound waves, so there's no problem. I mean, we can perform as many as we want, and there wouldn't be problem for the patient, or if the patient is pregnant or anything. We tend to go more for the ultrasound. Then it gives us real-time information. It's what I was saying, that it's very dynamic. I have the ultrasound in my hand and I move it around, look at this, oh, this looks like a lesion, or this doesn't, or let's look at here more carefully. Oh, let's look at this axillary ganglia or this. So you can change the test depending on what you find in the patient. That's very, very important from the physician point of view. And also it's a downturn of this technique. We will talk about that in the next slide. And also it has a very, very big spatial resolution. It has like, I think, the biggest spatial resolution of all the techniques, which is great assessing like very, very small lesions and very subcutaneous tissue, which is very important to know exactly the margins. And also we can perform interventional procedures in this in real time and with a very good control of the needle. So again, I'm just going to talk about this in the afternoon, so I'm not going to repeat everything, but it's very safe, and I personally prefer doing it other interventional procedures with ultrasound than in the mammogram, because I feel more comfortable, but that's something for myself. And what's downturns? The downturns is that it's heterogeneous, and this is the most important one. It's very dependent from the operator. Depending on who is performing the test, you will have a better or worse results. So if the person, you need a highly trained personnel to be able to perform a good ultrasound, and also to be sure that what you're seeing is correct. I mean, the fake positives and fake negatives rely a lot in the operator of the ultrasound. So most of the times we already have some background of the patient, we know on the mammogram, or we know other ultrasounds, but we have to do a very good assessment of the breast. We will talk about this later today, but we need to have a very good training to be sure that when we say there is nothing in this breast, we have seen everything. And the thing is that we cannot make a contour, because every time you perform an ultrasound, it's going to be different, because our hand is different, the position of the breast is different, the patient is different. So it changes more than the other. We have controls with ultrasound, but it's more heterogeneous than the other techniques. Also, I mean, as I said, it's very variable, and we cannot see microcalcifications. And that's something we addressed already in this talk, that microcalcifications are a way of cancer, one of the presentations of cancers that can only be seen nowadays by the mammogram and also in MRIs. But this is key. If we cannot see technically, we cannot see, even if you have the best ultrasonographer, the best trained doctor, and it cannot see microcalcifications in a breast, you cannot say that that breast has no cancer. And that's a big limitation of the ultrasound. This is a big problem when we are talking about fake negative. We could say it's a negative, but we are not seeing microcalcifications. So all these factors make a higher fake negative and prevalence in this test. I mean, I love ultrasound. It's my favorite of the ones we will be seeing, but it has some downturns. Here it's how it's done. I mean, you will talk about this more later, but this is how a normal ultrasound looks. This is part, it's more superficial. This is how we put the probe, and you have the skin here, glandular tissue. This darker here, it's the muscle tissue. Then you have rib with an acoustic blackout after that, and there is the lung. So you can see this is not very profound. It's maybe 2-3 centimeters, but high resolution. You can see the muscular fibers here. They're really good definition. I mean, this is very good for the soft tissue and breast. I mean, absolutely. You can see the names here. And also the same as we were saying in the mammogram, everyone has its breast, every breast is unique. So the more glandular, the whiter it is, the more fatty, the darker it is. But in breast cancer, as you will see later, it turns around, it's darker than the glandular. So with a more glandular breast, like a type D, you would see, it would be easier to see breast cancer than with a fatty breast. That's why I always say that combining different strategies and different techniques, it's the way to get the most of every diagnosis and to get the best diagnosis possible. This is what I was saying, that it's very important to be able, I mean, to assess that when you cannot see something in the mammogram because it's a very dense breast, or you're not sure, you recall the patient, is what also Anna was saying in the previous talk. You can recall the patient and do a combined read. I mean, you do the mammogram and then you do an ultrasound to be sure that what you're seeing is real, or that what you are not seeing there, I mean, there is no pathology, then you can say, oh no, there is no. So there's, in this highly dense patient, 26.7% of recalls. And then we will talk about the magnetic resonance. Let's see how well, time it's quite okay. Sorry, magnetic resonance, it's like one of the highest technological tests we can perform. And I will talk a little bit about the physics of this test, and to be like sincere with all of you, this is super complicated. I mean, I sometimes don't even understand it. But the physics of magnetic resonance, it's based on the magnetization of the water molecules. They all follow, we need to align the water molecules in the same plane and to see how they move, how they shift from one direction to the other. And what we are seeing, to be very fast and easy, it's how much water is there in a lesion. So if there are lots of cellular, and we have less water. If there's fat, there's less water, because fat is an hydrophobic substance. But if there's, for example, in the next to the brain or in a cyst, there is more water, how the water moves. But it's all about the water. That's all what we need to see. And how it works, this is, I mean, just, I always put this example, and well, my aim is not to tell you like how works the resonance and all this, but just for you to have an idea. If someday you, let's try not to, and wish you don't have to get an MRI in the near future, but if you do, and you will hear a big sound, like it has a huge sound, and you will see why is this. So because what we are doing, it's with a big magnet, we make a frequency of energy, a change of energy that's proportional to the frequency of the water molecules, hydrogen molecules in your precedence in the body. So it makes this resonance. It gives energy. It transfers energy in space without need of contact. And there's a video here. Yeah, this is an example of two. That's why I put the diapason here, because if you have two diapasons that are the same in the same tone, and you make one vibrate, the other will vibrate even if they don't touch. And this is what this man is doing. Let's wish this works. Oh, it's opening. No, well, never mind. Well, it opens another video in the internet, so never mind. That's what I was saying. If you make the diapason, if you touch the diapason and make it move and vibrate, the other diapason next to it will also vibrate in the same frequency if they are the same tone. If they are different tone, it's not going to vibrate. And that's what the magnetic resonance uses to transfer energy to our water molecules or hydrogen molecules in the body without touching it. And that's why you will also feel heat when you get into the resonance, because it's giving energy to the water molecules in our body. After this, this is how, I mean, it works. It tells how much energy is there. I mean, if you have a lot of water, you have more energy in transferred in here, less water, less energy. But I mean, I think this is very technical. It's not the aim of this talk, and let's assume that all the magnetic resonances work by magic, and it's what most radiologists think. So I think this would make it work also for us. So, well, let's talk a little bit about their magnetic resonance tests and why it's a good test or it's not that good. First, we'll talk about the good part of the magnetic resonance. It has a huge, very big, high resolution, spatial resolution, less time resolution, but very good spatial resolution. Has no variability. I mean, what you see is what there is, and it sees everything. You can even see lungs, and sometimes we are performing a breast MRI and we see a lung cancer in the MRI. It's not usual, but we see it. So you can see everything. That's why. Yes, there's multiple lesions. Sometimes we find a patient who has one lesion in one breast and two in the other one, or three lesions in the same breast. So you can assess multiple lesions, not just one. By time, you can give us the staging with the lymphatic nodes involved, and we can also perform interventional procedures and to get some cells and to get some tissue and to know what kind of illness the patient is having, what kind of cancer, which is very important. We'll talk about this in the first talk of the afternoon. Problems of this technique, but first is it's very slow. It takes from 35 to 50 minutes to do a magnetic resonance of the breast. And also, if you have to perform a biopsy or an interventional procedure, this time it's higher. So it takes a lot of time, and it's very time consuming for the clinic, for the patient and everything. It's super uncomfortable. I mean, I don't know if any of you have ever had a MRI, but you have to stay very still. And also in these patients, you also need compression of the breast. You need to compress it. So you are facing down. You cannot be facing up. You're facing down with your stomach pointing to the table. So it's very claustrophobic with the breast compressed in a small tube that's super small for 30-50 minutes. That makes a big sound, and you are alone, and with all this heat, and also it's cold outside, it's heat inside, it's contrast enhancement and everything. So it's very uncomfortable and very unpleasant, and some patients cannot undergo this procedure because of the claustrophobic or because they cannot tolerate it. And it's not a small number of patients. And this is why also an alternative like the mammogram with contrast would be great for this patient. It's not accessible to all. I mean, as we said, mammogram it's in all, like anywhere you can find a mammogram, you can find the ultrasound anywhere. I could be having an ultrasound machine in my pocket right now. but I cannot have an MRI machine anywhere. I mean, you need a big place to have them. You need a special room, you need to put helium, you need a lot of electricity. It's just in some very specialized places. And well, it's just not accessible to all the population, and it's also difficult to see calcium. Also, another problem is that, as I mentioned, you need contrast. You need to put contrast to be able to see the lesions and to assess correctly all the pathologies. And this is what I was saying. This is the position you will have to position a patient to have a breast MRI. And this is also with compression, so it's not pleasant at all. This is how it is seen, cancer in magnetic resonance. You can see it's highly very big resolution. It's easy to see. In here, you have this arrow pointing it. The arrow doesn't appear in the resonance normally, but you can see how this is a contrast-enhanced mammography. You can see contrast, and this is the lesion, where you can see very easily. And here, absolutely, I mean, this is a huge lesion in here. This is a cancer in the right breast. Yeah, for those of you who don't know, I will be always talking like what's in our left, it's the right, and what's in our right, it's in our left. Just it's like that in radiology, just don't ask why. So we are a little bit dyslexics in that way. So well, this is how you see a cancer in an MRI with contrast. And also we can have multiple techniques, as I said, you can combine them. Why? Because, for example, the mammography, it's worse for, as I said, this is a small resume of everything. There's breast, post-surgical, it's bad for prosthesis and it irradiates, but the other ones are very good in all this, are good for prosthesis, don't have irradiation, can look at post-surgical procedures, so it's quite. The ultrasound cannot see calcium. It's very time consuming, which is also MRI, and it's operative dependent, but mammogram and MRI are not. And these are the downturns of the MRI, which have their upturn in the other ones. I mean, for example, you don't need contrast in ultrasound, and in normal mammography, it's time consuming and all that. I mean, when you know all of this, you can perform different techniques, you can get always the best assessment and the best options for each patient. And I think this is very nice. This is, for example, when I say multiple techniques, you can see here, this is 2 ultrasounds in your right and it was ultrasound in your left, where you can see how the cancer lesions are seen. This is also another lesion you've seen by ultrasound in here. This cancer, as I said, it's dark in a white underground, and you can see in the MRI all this. This is how it's seen the cancer. The same, this is a dense breast. I'm not sure if you could say where the cancer is, but you can see here in the ultrasound, you have it here. It's dark in here, and you have the MRI where you can see the cancer in the right breast. Another thing that we said is that there are these with patients with prostheses that are very difficult to assess with mammogram. It's difficult to see here if there is any lesion, but see the ultrasound, how you can see there is a big cancer in here. And now if we go back to the mammogram, sorry, you can see here, this is the lesion, but maybe we would not have seen it in for sure in this. So now we will talk a little bit very fast about the BIRADS system, because I know we're a little bit late, but since I'm giving both, I already managed this way because I think it's very important to know the other part. So when we talk about the BIRADS system, we talk about the standardized reporting system. So we all talk the same. When we say nodule, everyone says nodule. When we say asymmetry, everyone says asymmetry. So we all talk the same, and when someone knows how to read it, knows always. So everyone who is looking at breast pathology uses the BIRADS system always. Also, it's a way to know how malignant is the lesion we are seeing, how malignant is what we see. And then it's a way to decide what to do, and that everyone decides what to do. So if you come to me, go to Nacho, you go to Anna, I don't care. We will all do the same. It doesn't depend on the doctor who's seeing you. It's not dependent on the experience. It's what it is, and it's proven to be like that. So it's a very strict method, and you will see it now. So what do? We can do nothing. We can do a follow-up. We can do another image, or we can do an interventional procedure depending on the risk of the cancer. So we say, oh, this is a BIRADS 2, for example. That's very good. You can do nothing. Let's do a follow-up or something. Or we can say, oh, this is a BIRADS 4. This is very bad, and we should do an interventional procedure and know what it is for sure. We cannot wait 3 months or 6 months or come back some other day. No, we are doing interventional procedure. That's why the BIRADS system is very useful. And it's been replicated in other pathologies, like in thyroid, there's the T-RADS, and in liver, it's the LIRADS, and everyone, it's some RADS. But it's super, super useful. So everyone talks the same and does the same. It's a very important thing for quality in the treatment and diagnosis of the patients. So this is key thing. This is the most important message we can have in this talk. It's that it's a way that we all do the same and all the patients get the best diagnostic possible. So this is how the reporting system works, and the standard reporting, every reporting in breast should be this. Why we are doing it, the indication, what's the breast composition, A, B, C, and D. We are just said it, like A, it's very fatty, D, it's very glandular, very white in the mammogram. Image findings, is there a mass, is there symmetry, is there calcium? If there's a distortion, then we have to compare it with the previous studies, is there were? And after that, with all this information, we assess the category, and we'll talk about that. And then after that, with the category, we can give recommendations and communicate with other clinicians. So this is how we describe things in the mammogram. So you can see the breast composition, A, B, C, D is very fatty, fatty. We will talk about this in each of the pathologies, so we don't have to work on that. And well, as we said, the composition, as I said, the classifications, you can see, I told you before, this is micro classifications. You can see these white dots here are calcium. They are very, very small. They are like 1 millimeter, 2 millimeters. So, and they are grouped in the same place. This is a cancer. So when you see this in a patient, you have to give a higher risk. So also going back, as we said, the classifications, what's the morphology, the mass, when we talk about the mass, if it's oval, if it's round, if it's irregular, if it's obscured, if it's circumscribed, we will talk about this and we will see it in the ultrasound lecture I'm going to give after that. And well, and all the associated features like skin retraction, nipple retraction. Then also we have a different standard reporting for breast ultrasound, which you can see here. We also talk about the breast composition, but we don't have ABCD, we just have ABC. We will talk about it in the ultrasound talk, and also what's it look like, the lesion, so the shape, the margin, the orientation. We will go in deep in the other one, so we are not looking too much into this one, just that you know that this is how to be reported. I cannot make a description from myself, like, no, it's serpentinous, I mean, it looks like a snake, or it looks like a dog. No, you have to say oval, round, or irregular. That's the shape. You don't have another descriptor. You have to use one of these three. You have to decide, and when, depending what you decide, this lesion is going to have better or worse prognosis. You cannot say the orientation is not parallel, not parallel. You have to give one. No, this is how you should write things, because everyone talks the same language, and it doesn't matter if I write it, if it writes another doctor. We all write the same. And this is very important. If any of you wants just one slice, this is the one. This is the most important. Depending on the final assessment category, what we're talking in here, the final assessment category, the 5, gives a malignancy suspicion. So being 1 and 2 benign, you have 0. 1 is you find nothing, and the 2, if you have a benign finding, for example, a cyst or something, we will see it in the next talks. The 3 is probably benign, so you need to do what? A short interval follow-up, like 6 months or something, malignancy rate of less than 2%. Then 4, it's suspicious. You have 3 categories, A, B, and C. It range from 2 to 10, 10 to 50%, and more than 50% malignancy suspicion. So what you have to do with this is get some tissue. You cannot make this patient go to their home, take a go holiday, come back in 6 months, because then if it's cancer, it would be spread and it would have a worse prognosis. High, it's a highly suggestive malignancy, it looks horrible, you need to test diagnosis. And 6 means that you already know that that's pathological, and you need to go to a surgical intervention or whatever. I mean, this 6, I know it makes like no sense to some of you, but when, for example, you have already done ultrasound and you are, I mean, the patient has already gone to the surgery and has a new lesion, and you see, maybe we're going to do an MRI and you see this lesion, you already know that's the same cancer that steals some of their after their surgical procedure. So it's a 6. Or if you have done an ultrasound today and you do an MRI tomorrow to see how this looks like, it's a 6, because you already know that's cancer. And a 0 category is that you cannot classify in any of that, you don't know what is that, and you need to do another examination. For example, that would happen with a very dense breast in mammogram, that you need to do an ultrasound. So that would be a category 0. You cannot say it's 0% or it's 40% suspicious, because you cannot see it. That's how it works a little bit. That's the most important part with it. So now, like for the final part, we have these 5 minutes before the next talk. Let's play a little bit. This is a mammogram. We are seeing this lesion that's speculated by the limited lesion. It has some retraction of the skin. It gets there. So it's quite suspicious. This is very, very suspicious. In fact, it's a BIRADS 5 lesion. So we should do a biopsy with this patient. And in this case, it was an adenocarcinoma, it was cancer. So, I mean, this is how we would proceed. And what about this? So this is a very circumscribed nodule. It's it has some calcification inside. You cannot say because it's not speculated, it's well delineated. It's round shaped. I mean, you can draw the margin of this nodule. So what would we give to this? We do a biopsy, we say this is cancer, don't worry, lady, come back in 2 years. And so in this case, we have BIRADS 3, and BIRADS 3, you cannot stay with this. You have to even put a BIRADS 2 or a BIRADS 4 at some point, because it's not determined, it's not sure what this is. So we make a follow-up in this patient. You can see in 6 months, that's what it was saying here. So in BIRADS 3, you have to make a follow-up. In 6 months, it looks just the same. In 12 months, it looks the same. And it was downgraded to BIRADS 2. And this was a benign finding. So no worry, this is benign. So well, this was more or less this part of the talk. I think we're perfectly on schedule. And if there are any questions or anything, please, I'm here for all of you to ask anything.
Anton, I have a question.
Yes,
actually two. So the first is, why do you need compression to get a better quality of image?
Yes, because of the, yeah. Yeah, I answer one and then the other, if it's okay.
Yeah, sure.
Yeah, so yeah, you need compression because of the amount of tissue that you need to, that overlaps. When you make a X-ray, that's what you're acquiring. So you're overlapping different parts of tissue. So if you make a compression, it spreads a little bit. So it doesn't overlap the different tissues, and you have a better resolution, because then the glandular tissue will overlap, and then maybe you have a lesion here, overlap, and you cannot see it. If you compress, all the tissue spreads and you have a better resolution, better spatial resolution, and absolutely, it's that why you need the compression in the first part, because of the X-ray. It's just one ray acquiring this. For example, if you do a chest X-ray, for example, you have all the structures in overlapping each one another. And if something is behind the heart, for example, you will not see it. That's why we put two different angles. So when you don't see it in one, you see it in other one. That's why this is overlapping.
Yeah, that makes sense. Yeah. The other question is, do you use any type of functional ultrasound, or even do you use any contrast agents as well, microbubbles or things like that?
I think in ultrasound, I think it's not used. No. It's, we don't really use that. We sometimes use the Doppler effect, but it's not contemplated in the BIRADS system. There are some techniques that use the infrared, I think it's called like that, infrared to know, but it's not validated. But no, we don't have this quantitative thing. I know there are some studies that have been done with elastography and to know how it works, but that's nothing. That's something that we don't use in the clinical practice in a regular base.
It's not standardized. Yeah, I understand.
No, it's not standardized.
Okay. Yeah. Thank you.
Welcome. Okay, so if there is none other question, we can pass to the next talk. It's Stefania, who made it recorded. So we'll put the record, and after that, if there's any question on that, I will be here just to answer. Maria Paz, do you think it's possible to put that?
Yes, 1 second.
Yeah, don't worry. I just silence myself. I'm around.
Morning, everybody. My name is Stefania Orlando. I'm breast radiologist. I had my degree in Milan as specialist in diagnostic imaging, and I started to learn about breast radiology in Istituto Oncologico Europeo of Dr. Veronesi. But I discovered in 2009 that breast radiology is better near the sea, so I come here to Barcelona, and I work in Hospital Vall d'Hebron since 2019. I will talk about mammography with and without contrast. We know that is the most important and basic tool in radiologic clinical and screening setting in breast radiology. Is the basic imaging in breast cancer. So it's used in clinical and screening setting. It means that we can use it even in symptomatic women with palpable lump generally, or any other clinical symptoms of breast cancer, and in asymptomatic women. Everything started with Albert Salomon in 1913. He is a German surgeon that started to apply X-ray on on breast tissue. So he discovered how cancer can appear by under X-ray. So we had our first knowledgement about the morphology and the radiological appearance of benign and malignant lesion. He discovered that breast cancer can appear as microcalcification too, and he left us a lot of knowledge about the way of breast cancer appear in radiology. And just like curiosity, he is the father of Charlotte Salomon, that is a Berlin painter who died in the Holocaust in Auschwitz. So in 60s, we start with technological advance. We had our first technological equipment to do mammography, and of course it was very different. And generally was not compression of the breast was not applied since 1965, when compression of the breast parenchyma was introduced as a fundamental requirement for a mammogram. It means that we can obtain a mammography, and radiographic image without movement, because breast is soft tissue. And we can reproduce the technique in the same way. We use different kind of paddles, like I show you in the image on the right. And the technician use different kind of paddle depending on the kind of projection we want to obtain. So we finally passed from digital breast mammography, from conventional mammography, when we had the film, the traditional film X-ray, to digital breast mammography, also known as full-field digital mammography, that replaces the X-film with electronics that converts X-ray into a mammographic picture. So we can read our mammogram in specialized display. So about the technique, we perform the mammogram with both standard craniocaudal and MLO projection of both breasts. So the breast is compressed in the craniocaudal direction and in an oblique direction that includes the axillary region. So this is the appearance of our mammogram. On the right we have the and we have the craniocaudal, and on the left we have the MLO. We divide all the quadrant in superior and inferior, upper and lower. And on the right, in the craniocaudal, the superior part corresponds to the outer quadrant, and the inner part is displayed in the inferior part of our display. So we generally divide every breast in 4 quadrants. So some notion about breast anatomy on mammogram. We have an MLO projection. The white triangle is the axillary region, and this is the pectoral muscle. We have a small nodular image that corresponds to a lymph node. This is a normal lymph node with a central part made of fat tissue. We have a very thin line that represents the skin. On the center, we have a thin, the nipple area. The white represents the glandular tissue, and the black represent fat tissue. Generally, in a normal breast, we can find fat under the skin. This is the subcutaneous fat, and we can find fat beyond the tissue, the glandular tissue, and this is a very important area that we have to see always black, and every kind of findings we can find in this part of the mammogram can be considered suspicious, and we should study it. So we have other kind of linear white density. For example, in this image on the left, we can see the retroareolar area, and we can see, for example, vessels, we can see ducts, we can see Cooper ligaments. These are small, very tiny, small ligaments that anchor the breast tissue to the skin, and fibrous strands that constitute the architecture of our breast. So the most common findings in mammography and the way cancer presents itself is generally like masses, like asymmetry, like architectural distortion, like microcalcification, and we have to find any other small sign like nipple retraction, skin thickening, or lymph nodes that can help us to give a correct interpretation to our image. I want to remember that radiologists generally use a common lexicon that was introduced from American College of Radiology, and this is the BIRADS. We are at our 5th edition. So this is the appearance of, for example, of an asymmetry. I show you just the craniocaudal image. So on the left, we have an asymmetry. Asymmetry is considered a white area of tissue that cannot be represented in two projection, or we cannot define a real margin of it. So this is an asymmetry, and it can correspond to normal glandular tissue, or sometimes not. Then on the center we have a mass. When we have a mass, we identified something that has a volume, and we can see it in both projection, and we describe margins. Normally, the worst way to present, and the classical way to present of a cancer is with speculated margin. And then we have lobulated margins, well-circumscribed margin, or sometimes margins that are high from the overlapping of the tissue. And finally, microcalcification. There are a lot of type of microcalcification that can be expression of benign pathology and sometimes of malignant tumors, concomitant with invasive carcinoma, or sometimes like in situ. It means a carcinoma that grows inside the duct, so it cannot metastasize. It cannot do metastasis. So the interesting thing that we have to know is that the appearance of breast on mammography varies among women, so depending on the amount of fat, stroma, and glandular tissue. So we can describe four type of breast density. From the left to the right, we have fat tissue, fat breasts, fibroglandular breasts, heterogeneously dense breasts, and extremely dense breasts. Identified like A, B, C, and D. We consider dense breasts the type C and D. So this has very important consequences in the sensitivity of our mammography. So it can be very, very low, till 40 or 30% of sensitivity in extremely dense breast. It means that breast tissue is white and cancer is white. So this is the reason we cannot see, or we can lose cancer in a very dense breast. So what exactly means breast density? Breast density is a highly condition, but can be influenced by age, the age of menarche and menopause, from body mass index, hormonal treatment, alcohol abuse. And we know that almost 47% of the population has a very dense breast, very dense or heterogeneously dense. This is the distribution of breast density in the United States, and it's almost similar in Europe because we have the same lifestyle. And but another very important discovery that was made in 2006 is that dense breast is related with a relative risk of incident breast cancer to 0.9 more for women with heterogeneously dense breasts and 4.6 for women with extremely dense breasts. It means that is a new, important, recently emergent breast cancer risk factor that we consider like an intermediate cancer risk. So women with dense breasts have a higher risk to develop breast cancer compared to women who don't have dense breasts, and dense breasts make harder for radiologists to detect breast cancer on mammogram. So this increases the risk that cancer will be missed. This is the reason we have to put some attention on dense breasts, because some cancer can be easily missed. So maybe we have to use any other techniques or tools complementary to mammography. So this is what I want to show you. On one side, the overlapping breast density can hide breast cancer, and this is one of the cases. Because, for example, in this area, in the conventional 2D mammogram on the left, we cannot see anything, but in the 3D or tomosynthesis view, we can see a parenchymal distortion, and it was a invasive cancer. But on the other side, the overlapping breast tissue can mimic breast cancer. So we have an asymmetry, for example. We perform an ultrasound and it was just a cyst. So it was like a false positive result. So what we can do to reduce false positive, we have to be calm. This is the false positive findings are a problem in the screening setting, because the loss in specificity and the recalls for the patients can cause psychological stress and morbidity and unnecessary interventional procedures. But we have a lot of engineers like you and radiologists like me that can have to keep calm and invite patients to do and get their mammogram, because finally the benefits are bigger than the negative effects. So we had some other tools that can help us. So in 2011, a new technique broke in the world of breast radiology. It's tomosynthesis, also known as 3D mammography. Is a technique that uses multiple images of the breast that are taken from different angles, and then they are reconstructed from a software in a three-dimensional image set like this. So the acquisition is really fast, in some seconds. So we have a lot of images like a CT scanner, and is like a CT scanner. So we know from literature that masses, distortion, and asymmetric density are better visualized with tomosynthesis. This technique was admitted from Food and Drug Administration in 2011. And we also know that we can obtain, when we start with this technique, generally we make digital full field mammography. This means to the double of radiation till we discovered that we can obtain a synthetic mammogram from tomosynthesis. So the result improvement in image quality is not at the expense of increased radiation dose, because Kane in 2014 discovered that tomosynthesis with synthetic 2D image is accurate as tomosynthesis with conventional 2D image. So we can use synthetic image like with the same sensitivity, sensibility, and accuracy than to the conventional mammography. And then in that years, we had a lot of studies that confirm that with tomosynthesis, we can reduce recall rate in screening, so reduce false positive results, about 40%, and we can obtain an increasing of the 40% of in detection of invasive breast cancer. Generally, they are very small breast cancer. That is the objective of our screening, so to discover small cancer that had not spread to the lymph nodes and that and with the best prognosis. So I want to show you that with tomosynthesis, with this video, you can study better and define the margin of the masses. For example, this small nodule in the upper outer quadrant can be missed because it can mimic a small lymph node, intramammary lymph node, for his typical location. But if we see it with in tomosynthesis slices, we can see that his margins are not so well delineated and well defined like a lymph node, but it is a very small invasive breast carcinoma, ductal carcinoma. And this is another example. In this video, we have a fibroglandular mammogram, mild density. And we can discover in the inner quadrant of this craniocaudal projection at the apparenchymal distortion that was a lobular invasive carcinoma that generally presents like a distortion. And finally, we have the latest discovery in the world of breast radiology is contrast enhancement mammography. This technique is based on tumoral angiogenesis. Tumoral angiogenesis is the anomalous increase in blood vessel formation associated with that is associated with development and growth of tumors. So it used the same principle as breast MRI with contrast, and so we can obtain the same kind of information. The big benefit of CSM is that combines the iodinated contrast medium with standard mammography, so we can obtain morphological and functional assessment of a lesion. So we can see the margin, like the morphological finding that we can see generally in a normal and conventional mammography, but we can see how his behavior with contrast. So it's a dual energy imaging that use the iodine contrast agents absorb X-rays at different energies compared to normal breast tissue. And this is the reason CSM works. So we obtain a pair of low energy and high energy image is obtained after the administration of iodinated contrast agent in both craniocaudal, MLO, and sometimes mediolateral projection for both breasts. So these data are processed, and a recombination image is formed by subtracting the low energy image from the high energy image to enhance abnormal contrast uptake areas. And this is the result. We have the low energy image on the left that is very similar to a normal mammogram, and we know that this image can be used with the same accuracy to obtain morphological finding of the findings of the tumor of the lesion with CSM. We have the high energy image that is not diagnostic, and this is the image that is subtracted to the low energy image to obtain the post-processed CSM. The post-processed CSM on the right is the image that we use, and we generally call contrast enhancement mammography, where all the parenchymal tissue is black and just the lesion is enhanced with contrast and it appears white. So this is the technique. We generally inject iodinated contrast. Is the same that we use in CT scanner examination. We inject it, we wait 2 minutes without compressing the breast, so we allow that the contrast go through all the vessel and all the parenchyma, the glandular parenchyma, and after 2 minutes the technician can start to perform a normal mammogram with all the views for both breasts. So the entire examination is performed in almost 6 or 7 minutes, and it can be the last projection can be done. We can do the last projection till the 8 minutes, because after this time we have not enough contrast in the parenchymal tissue, so it can be no useful. So the radiation dose is almost the same that a conventional digital mammography. This plus in radiation dose is due to the low grade energy image that is bigger than the conventional digital mammography. So we have some studies that confirm that patient can tolerate CSM more than MRI, maybe because patients already know what this kind of technique is, because every woman knows mammography, but not every woman knows MRI. So it's very, the reason is that it's very fast compared to MRI, and it's not so, it finally is well tolerated than MRI. Limitation are renal insufficiency, allergy, and no adverse reaction to iodinated contrast agents. Pregnancy and breast implants are considered a relative limitation, because we can obtain some artifacts that can reduce the performance of our image. Contrast reaction are the same that in other contrast reaction really are majority of them are mild. We have to inform the patient about habitual transient minor reaction like warm flush, altered sense of taste, and we have to prepare the patient and advise him, and we have to we need to have all the drugs and equipment to in case of a very severe reaction that, I repeat, are not so common. So the benefits of CSM are low compared with MRI, are low cost, readily available, because we have at the moment we have the image. MRI is almost 3,000 images. Is efficient and a short time as a short time of acquisition. Is easy in training and maintenance, is quick to perform and report. Radiation exposure is similar to full-field digital mammography, is a better tolerated compared with MRI, and we obtain statistic images. So this is easy for surgical review and planning, so is better understood for clinicians and for surgeons, and has high sensitivity and specificity superior to full-field digital mammography with or without ultrasound, and has a comparable accuracy similar to breast MRI. So the clinician assessment. So when a patient enter in our institution with a suspicious palpable lump, in screening recalls, in local staging preoperative evaluation, in dense breast, because I explained it before, when we have some contraindication for breast MRI, like pacemaker or metallic devices, and in monitoring responding to neoadjuvant chemotherapy, but we need more evidence about that. So generally we use in our hospital, we use in a symptomatic patient in recalls and in the symptomatic setting. So we perform CSM in the same day when the patient is evaluated inside to the Unidad de Patología Mamaria to discover breast cancer or exclude it. And finally, we know that CSM is very good in size, in tumor size and extension estimation. It's similar to MRI. I want to show you in this case, for example, we had a woman of 47 years old, asymptomatic, without family history of breast cancer or toxic habits, with a fibroglandular density breast. We have a speculated lesion mass on the upper outer quadrant. We perform a contrast enhancement mammography and we confirm the mass enhancement. The size in ultrasound was 17 millimeters, and in MRI and contrast mammography is 35, and it's the same size we discovered in the anatomopathological specimen. We have to talk about background parenchymal enhancement too, because like we can see in MRI, we have a contrast of the breast tissue. We don't know the reason. Maybe it's not correlated. We know that in some studies it's correlated. It's related to hormonal situation of the patient, but not always is like this. We divide it like an MRI and minimal, mild, moderate, and marked. So in moderate and marked parenchymal background enhancement, we can have some difficulties in discriminate small lesions, because the parenchymal enhancement, like breast tissue, can hide the lesion, especially if the lesion is not so patent. So if it's not so avid of contrast. So finally, I want to show you some cases.
Stefania,
Yes.
we have only 1 minute left.
1 minute. Okay, I will show you just one case. We have dense breasts with a 44-year woman with a SCRD breast. We saw in the inner quadrant in the craniocaudal image a mass. We perform an ultrasound with an hypoechoic oval nodule with microlobulated margins. We perform a biopsy, and we have a carcinoma. Then we perform a contrast enhancement mammography, and we see more nodules, so we can do a second look ultrasound, and we discover 2 more lesions. So CSM benefits are that is immediate clinical useful, that give immediate clinical useful information in symptomatic settings, is efficient, cost effective, is short and it's well tolerated compared with MRI. Is easier permit a easier review and planning for surgical team, higher diagnostic accuracy than full field digital mammography, high accuracy in tumor size estimation, and more evidence is needed in neoadjuvant chemotherapy response. So just remember that a good breast radiology has to work in the multimodality correlation of all imaging in order to obtain a final report with the final category BIRADS category. Thank you, and grazie per l'attenzione.
Thank you, Stefania. Ciao.
Adios.
Hi, everyone. Well, if there's any question about Stefania's presentation or anything, I'll be pleased to answer. If not, we will proceed to the next talk about the breast ultrasound. So let me know. Okay. Perfect. So we'll go to the breast ultrasound presentation. Perfect. Can you all see the presentation? I wish so. Perfect.
Yes.
Okay. Well, we've already covered the mammography. Then now we have to talk about a little bit of the ultrasound. But I think it's one of the interesting part of the training today for us for the QUSTom program. It's what we do. And then we'll talk about the MRI imaging, which I think it's going to be very, very interesting because it's the latest technique done in breast imaging. So, well, let's start. I already talked a little bit about the ultrasound and when we talked about all the introduction and everything, but now we will focus a little bit more. This is one of the ultrasound devices that we have here in our facility. And well, this is what we were saying. Second, this is the linear probe. That is the one that we usually use here in the breast imaging. But I was talking about the convex one. It's this one you can see here. I don't know if you can see it, but you can see that this is the linear, the one that's more close to the patient here because the one that we are using. But we also have this small convex ultrasound that's more suited for abdominal imaging, for example, liver or everything. I mean, we still are in a hospital where we do more things and not only breast cancer imaging. And well, sometimes we also do abdominal. I mean, if a patient has any kind of kidney problem or anything, we also use that. But just for you to see the different probes that we use, and this is the ones that have a higher resolution because they have they can use higher frequencies and is the best for breast and for musculoskeletal, as we just said. ¿Por qué no puedo pasar? Second. Okay. So this is how an ultrasound machine works. It's more or less the same that a bat does, or the same as any radar or anything. We send waves in a medium that's usually liquid. It's very bad in the air. I mean, air, it's terrible for ultrasound reception and ultrasound imaging. We will see why. And this impacts with a tissue or with an object and returns to the receptor and to the emitter, the same thing in this case, and we receive it and we can know how far it is and how dense it is. In this case, this is the same way as a ultrasound machine works. We have an original wave that touches the object and returns, and with that we can know what's the distance, and also depending on how hard the object is or how difficult it is for the waves to pass through the object, the number of waves that return will be more or less, and we'll have a higher or lesser frequency, and we can draw this object. So we can, with this technique, we can draw a little bit how is the inside of the person based on the amount of waves that return and how these waves are. I mean, depending on the frequency, on the behavior, or their velocity and everything, we can know what kind of tissues have gone through these waves and how hard is the tissue. See. This is how in a breast image, we saw something like this before. It looks like, for example, this is bone, which reflects all the waves that arrive here. So there are no waves behind it, and you can see it's absolutely dark behind. And well, this is a proof that, I mean, this is calcium and what happens with very, very dense tissues. Also here we can see there is air, because this is the lungs. So there is no good image behind this, because I mean, air does not transmit with the sound, it just reflects and it disappears. So we have very high resolution in the breast tissue and the subcutaneous tissue, but once we touch the bone and we get to there, it disappears, it's terrible. So this is a key thing when we talk about ultrasound imaging in breast. So at the beginning, we were talking about that we need the radiologists to be very well trained in breast ultrasound to be sure that the quality of the image is enough, and to know that we are not having false negative or false positive images. And this is how more or less the breasts explored in breast imaging. We have 4 quadrants that are represented with the center is the areola. So we have the periareolar part of the breast. That's all this part here. And after that, we have this, the superolateral and superomedial, and also the infralateral and infromedial, which are these hours. So whenever we are using the ultrasound, we have to point where are we and where is the lesion, so we can, if we repeat it or we do another ultrasound another day, we know where it is, so we have to put it. Also, we can put it with the hours, so well, being 12 the top and 6 in the bottom of the breast. And well, with this we can know where the lesion is, but we must make sure that we are seeing all the breast, and also that we are exploring all the ganglionar tissue. As I said before, we have to know if there is a lesion, where it is, and also to know if there is affected ganglia. This is very interesting, and we will go farther and more deep in this conversation later on this day, talking about all the ganglionar dissemination of breast cancer. But it has a very, very typical spread. I mean, usually first it goes to the axillary nodes here, goes to these axillary nodes, or if it's in the medial part, it goes to the internal mammary ganglia. Then from here, it can go upstream, it can go to here, to the supraclavicular, and when it changes one of these stages, it upstages the breast cancer. So in these cases, we have to report, we have to explore, we have to do an ultrasound of all these areas to be sure that if there is a cancer, we can say, I mean, it's a tumor just in the breast, or no, this tumor also has a ganglionar affection, or we're not sure, we have to do something else. So depending on what we find, you will have a stage 1, a stage 2, stage 3, or stage 4 cancer, and the treatment and the prognosis of the patient will be very different. So when we do an ultrasound, we have to explore all this region, like all this region that I'm pointing in the image, and we have always to look at the axillary ganglia. That is a key place of the metastasis and the extramammary affection of the cancer. So, well, once we know how to do the exploration, we have to remind a little bit about the BIRADS, that I said that it was the most important presentation in this training session. We will be going on there because it's the most, it's the tool that we use when doing the diagnosis and staging of the breast cancer. So, well, this is how a little bit reminder of everything. It's breast imaging Western reproductive system. It's an instruction to report and to decide what to do. Well, this is the one that we are using, that it was published the last edition in 2013. And this is something that we already seen, that how every breast is different. I mean, there's the glandular tissue that now we are talking about ultrasound, and now we can talk a little bit more. This glandular tissue we see white, and fat tissue and muscular tissue we see this darker. So the same here and everywhere. You can see this fat, it's darker here, and the gland, it's whiter. I mean, it's in white color. So it's just the other way around the mammography. So it's very important to keep this in mind. So sometimes it can be confusing. So when we to put this talk together and to make a little bit my mind, I decided to follow a little bit the BIRADS system. And then after that, I will talk about the examples, some examples, that so you can see how we work with the BIRADS system in the ultrasound, because I think is the most important part, and to be able to assess the lesions. I mean, everyone can like do an ultrasound. Well, not everyone, but you can do an ultrasound and say, oh, I see something dark, something, but you need to put it written, and you need to decide what to do and to know what are the problems and what are the limitations of the test. So I will go through this in the following a little bit the BIRADS schema. So first we'll talk about the homogeneity of the tissue. You can see, I mean, this is the how the gland is a very fatty glandula. I mean, you can see it's all dark. And once we go to the fibroglandular homogeneous, it's type B. So this is a gland and this is fat, fibroglandular, and it's homogeneous. And when you cannot see the difference between the glandular and the fat, you can see here there is the difference of the gland and the fat gland, and in here you cannot see. Everything is mixed. So this is a worse case scenario for exploring with ultrasound, because I mean, we said cancer is dark. So in these occasions, how can you say this is not cancer? Because it's dark in the middle. It probably is fat, but who knows? So, well, I think it's quite interesting to know all these stereotypes. It's different from the breast ultrasound and some of the mammography that we talked about. So you have to know the difference. So now we will go to the ultrasonographic findings, and we'll go a little bit to see how lesions are seen in the ultrasound. What are we looking for in the ultrasound? And after that, we'll show some cases very fast, but I think very didactic, and so everyone can know what we're talking about when we are seeing all the lesions. So we'll talk about, when we talk about a nodule, we talk about the shape, the orientation, the margin, the pattern, and the posterior features. So let's go around it. Shape is radius. It's circular, oval, with 4 lobulations or less, and irregular, more than 3. I put this color, code color here. So green is more benign and red is more malign. It's more malignant. So you can see a little bit for your brain to make the click with the BIRADS system. So if I say something circular or it's oval, it's more benign. It's irregular, it's less. The orientation, it's parallel to skin or not parallel to skin. This is very important. When you see a lesion that's parallel to skin, for example, this one, it's more benign. I mean, it grows with the tissue, I mean, it's inside the tissue. So it follows the skin. This is in breast and anything. If it's parallel, it's better. And for example, this case, you can see, let's draw it. This is the skin, and this is the lesion. Let's make a line. This is not parallel to the skin. So this is more malignant. It's a malignancy sign. You can see this is a hypodense, not really well delimited lesion. It's cancer for sure, but you can see what I mean when I say antiparallel. Then the margins. This is something very interesting to address when talking about breast pathology. This is a kyst. I mean, we will go around the kyst because kystic lesions are very frequent in breast, but this is water, okay? This is water surrounded by skin, by epithelial tissue. So this is water, it's anechoic, and you can see I can draw the margin perfectly with my finger, or in this case with the pen. So this is a very well-defined margin. This is a benignity, I mean, this is good. Okay, so when we see this, we define it and say, oh, this is more probably a good sign. But where is the margin here? Can you draw it? I mean, where does the lesion start? I mean, this is the lesion. No, it comes probably from here to here, probably. Yes, no, maybe this is also lesion. I don't know. Where is the margin? The margin goes this way, then comes here. It's difficult. It's very difficult to know where the margin is. This is not well delimited. I mean, that's a very clear example. Maybe you have a better delimited area down there. You can see in here, it's maybe easier to follow, but absolutely this area, it's not. This is a bad sign. This is probably a neoplastic lesion. It's cancer, probably. So, well. Then when we talk about pattern, we talk about how it looks like in comparison with the fatty tissue. I mean, it's very easy because the fatty tissue is next to it, because all breasts have some fat. And if not, everyone has some fat somewhere, so we can make a difference. And say it's more white, it's whiter, it's brighter, it's hyperechogenic, it's darker, it's hypoechogenic, and it's anechoic. What we saw with the kyst is absolutely black. And then we have other isogenic, just like fat, and heterogeneous and complex, which has a solid and kystic part. Kystic is anechoic. Sorry for, I mean, so many concepts, but I think that this is easier if we see it with an example. Second, this is anechoic, the same kyst that we were seeing before. This is a kyst, this is water, anechoic, black inside. This here, it's hyper, this is hypo, as you can see. This is hyperechoic, as you can see, but it's also heterogeneous because you have an hypoechoic part in the center. This is a bad sign in this case. Hypoechoic, this is hypoechoic. As you can see, it's not black, it is dark, but not black. This is hypoechoic, this is anechoic. Very important difference. This looks like a fibroadenoma, well delimited beautifully. You can see it's parallel to the skin. It's hypoechogenic. Then we have complex lesion. You can see here, this is the kystic part, you can see black, and this is an hyperechogenic part, which is solid. It's complex lesion. Okay, so also the same. You can see the difference when we are giving the degradation and talking in the BIRADS system. Then after that, we have the posterior characteristics. I mean, after the lesion, you can see this part here. This is the previous slides, so be careful. This is the posterior. So we have our probe here. This is the probe. We're looking this way, and this is the posterior of the lesion. So this is an important part because it tells us how does the sound behave around the lesion. So in this case, we have reinforcement, posterior reinforcement, as you can see here. Behind the lesion, there's a white part line like this. It's super typical of a kystic lesion or things that let the waves pass really easily. For example, this kystic, there's also, this is complex, but you can see there's this positive reinforcement behind. This is negative reinforcement, as you can see, it's darker. And also there's acoustic shadow, what we call this negative, what I just said, acoustic shadow. This is the lesion. If someone cannot see this structure here, and this you can see there's a shadow. Why is there a shadow? Because this lesion is very dense, it absorbs lots of waves, and not so many waves go behind. So there's a shadow behind the lesion. That's what we talk when we talk about posterior characteristics and reinforcement. Okay, this is very important. I think for me, it's one of the most beautiful things in an ultrasound, if we can call something beautiful in this case. So, as I said, let's play a little bit and talk about examples. Here are some types of lesion and what we can see. This is a kystic lesion. So we already said it's water, it's anechoic, well delimited, and a positive reinforcement. This is a fibroadenoma. It can have positive, negative, or I don't know, but it's well delimited, well circumscribed, hypodense, hypoechogenic. The cancer is echogenic, but it's irregular pattern. Margins are not circumscribed, are indistinct and everything, and glandular tissue is hyperechogenic. So as you can see, this is something, I think this is like the most important slice of the presentation, and it's the one I would give my residents if I had to tell, okay, go and search for something in the breast, look at this and just tell me what you see. So let's make it a case example, and this is a case example, and then we will play a little bit and say, hey, what can you see, what can you tell me? So one is, this is the fibroadenoma, this is cancer. So you have a regular, you have a sharp border, and this is uncircumscribed. You can have a irregularity here. For example, this is what we say an irregularity shape in cancer. The fibroadenoma has an horizontal parallel to the skin, and cancer with skin is not parallel. And the fibroadenoma has a posterior enhancement sometimes, and cancer has shadowing. I just showed you this case because now we will look at real examples. Okay, here we have lesions. I don't know if someone wants to describe something, but if not, I will do myself. Okay. Just in case someone wants to at some point say something, just write it in the chat or anything, or interrupt me. I will be pleased about that also. But well, this is what we said, the fibroadenoma before. This is the fibroadenoma. And the other one is the cancer. Okay, it's both are hypo, but this is well circumscribed. This is not well circumscribed. Lobulate, irregular margins. This has a shadow behind. This has this hyperattenuating behind. So posterior reinforcement. So this is the typical cases. So let's describe this. Okay, this is a well-defined parallel, probably, because this is skin, well circumscribed, and hyperdense, hyperechogenic lesion, and it has some posterior reinforcement. This is how it would be set in the clinic. But as you can see, it's isor or hyperechogenic. It's not typical fibroadenoma. It has maybe some calcium there, so this would be ranked not a BIRADS score, would be maybe a 3, something like that. So we have to do more tests. This was benign lesion. I had it written here, so well, no problem. So this, anyone knows what this could be, or if not, I just put this here. Well, this is oval, parallel, well-defined, anechoic. So this is clearly a kyst. We've been seeing it all day long. So, well, this is clearly benign. This would be a BIRADS 2, no further explorations, no need to do any interventional procedure. Perfect. And what about this lesion here? It looks familiar to us, I think. We already seen it. It's well circumscribed, hypodense, well defined. Maybe here not so well, but well, we have doubts. So the posterior enhancement you can see here, it's very beautiful. So we would say this is a fibroadenoma. I mean, it's, if I just gave you this, you said, oh yeah, this is absolutely fibroadenoma. It has hypo, yes. Oval round, yes. Well circumscribed, yes. Horizontal, yes. Posterior enhancement, yes. You can see, bam, 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 bam. Okay, so it ticks all the boxes. It's great. But no, it is not a fibroadenoma. This is breast cancer. So that's why this is just a guidance, but we cannot be sure 100% every time. As I said, maybe here it's not so well circumscribed, but when you see this lesion that's not 100% also antiparallel and everything, you cannot say, this is a BIRADS 2 and go home. You may say it's a BIRADS 3, let's do another exploration, let's make something else, or maybe you can upgrade it into BIRADS 4 or something like that, but you need to be aware of this. So this is very important, because if we had followed our little well, the typical things, we would have said, this is good, don't worry. But if we say this and we fail, this patient has a breast cancer that is not going to be seen, it's not going to be diagnosed, and probably will have problems in the future. I mean, worse prognosis and worse treatment. So that's one of the fun cases. Well, not fun, but one of the trick cases that we have sometimes. So, well, this is a little bit of the breast ultrasound. I think it's been a lot of information, but more or less you now have a view of how the clinic works and how we work with ultrasound. So thank you very much for your attention. I wish you like it, and I think we are super on time here. Yeah, quite. So if anyone has a question or anything, I would love to hear it.
Hello, hi, Anton.
Hi.
This is Stefania. Am I audible? Hi. My question is, what is the ultrasound frequency that you used for this probe? What is the frequency of the probe that you used?
Yes, the frequencies are variable. I mean, you can, these probes, and you can change the frequency depending on how deep you want to get. It gets to a 14, I think it gets to from 8 to 14 megahertz. I think it's the range of frequency we use here, but you can vary, and when you lower it, you go deeper, and when you have higher, you have a higher resolution, but also you cannot go as deep, so more superficial. The good thing is that most breasts, you don't need to go that deep. That's the little bit.
So did you try 3D ultrasound? Do you try 3D ultrasound?
I know we have it, but we don't use it.
Imaging or
the 3D ultrasound, you mean these probes that have a double, the big ones that have double?
Yeah.
We don't have it here. I know some specialties, like they are doing it in heart ultrasound and things like that, but we don't use it in a regular basis in the clinic. I know there is, and it has an advantage compared to the usual, but I think that we can see everything in here, but it's a good approach to the breast imaging also, I think.
Okay, so with this 2D ultrasound imaging, so you are trying to find, do you do something like a image processing after getting the image? Do you have something like a segmentation, or do you do some sharpening of the image after getting the image, or do you just look at the image, whatever comes from?
No, usually the same. I mean, when you acquire the image, it's already post-processed by the ultrasound machine. I mean, let me explain that. Different ultrasounds and different commercial equipments do different. You can see different how they draw the lesions and how they look the lesions. That's a little bit, but after that, we don't do a post-processing or segmentation at clinical in a daily basis, usually because it's very dynamic. You know, you see the lesion, you use the ultrasound, you see what I've showed you, like this is the lesion. Okay, you see it, you put a name, you post, and the only thing that sometimes we add to it, here it's the Doppler, which is how the blood arrives to the lesion, but it's not standard clinical care. I think with what we usually do is we acquire the image with our ultrasound machine. We take the photo, and then we proceed with what we consider better. For example, interventional radiology, or just go home.
Okay. So, like you take multiple images of the breast, like at different angles, and then like look at it separately.
Yes, absolutely. We look
Yeah.
at the breast, we do or everything we took, then we acquire, like we set the images, take the photos of the most representative areas if there's nothing, and if there's a finding, we look all the breast and then we focus on the finding. We take as many images as we need. I mean, if it's clear, so we take 3 or 4 photos. We put, so how, for example, if it's very far from the nipple or it's close to the nipple, or you can sometimes make propagate the image to see all the way of the trajectory to the nipple, because it's a very good place to put the zero, to know where to put the biopsy or everything, and all that. But no, usually it's very dynamic, so we just use the ultrasound as a way to help us, but all the diagnostic process is performed inside the radiologist, so it's just a tool in this case.
Mammography. Okay. Yeah. So how important is this calcification? Like, is it like you're not able to differentiate between the calcified cells and the other glands or in the ultrasound?
Yeah, that's a very good question. When I talked about calcium, it's in the ultrasound needs to have a lot of calcium to be able to identify it. Because if there's very little amount of calcium, like the ones we've seen before in the mammogram,
Mammography images, yeah.
Yes, you don't see it. Most of the times you don't see it because it's too small. But once you see it, you identify it because it's very, very dense, like super white, and it has acoustic shadow behind. And also it has if you put Doppler, that's something else, it has something that we kind of shining effect that it changes a lot the Doppler. You don't, it shines with Doppler. And this is when we say it's calcium. But the problem is that we are not sure we're seeing the microcalcifications with the breast ultrasound. So that's why we use the breast MRI, breast mammogram and lots of times.
Yeah. So my question is like, because suppose maybe the ultrasound that you're using is something like a 10 megahertz, or it should have a good resolution in general, but you are not saying the calcification in the sense like how important is this calcification? I mean, what is the size that you are expecting? Is it like sub-millimeter size, or
yes,
is it like, okay, if it is a sub-millimeter size, do you neglect? Yeah.
Yeah, this is a question that it's been going on for a long time, because I mean, it's what size you need to be sure that you're not seeing it. What size you need the calcium to be seen in an ultrasound. That's a very good question. The thing is that you need to see that there's calcium. I mean, when you see microcalcification, which it's an anatomopathology, it's defined with anatomopathology, like in a micro, 5 micro, something like that. They mention when you see it in the breast mammogram, and you see 1-2 millimeters, that would be great. But the thing is that you see them in the mammogram and you see it in the ultrasound. This is more or less the importance of this is that some cancers only show this characteristic, only show calcifications. So you cannot make a burden like say, oh, less than this is not important. It's presence or absence, you know? So if it's present calcium inside of the lesion, there is, you need to be able to see it.
Be visible.
Yeah. Yeah, it's we had this discussion the other day here. It's like a more philosophical thing. It's what's the dimension, but we ended up saying we have a gold standard test for this. That's a mammogram. So if the mammogram shows it, the ultrasound need to show it to be able to have to be the same. But if the mammogram shows it and the ultrasound needs to show something, it's that the things that nowadays with the ultrasounds we have, we cannot be sure whether we are assessing them.
Yeah, I just need to. Yeah, thank you.
Yeah. Okay. If there's not other questions, I think we can proceed to the next. Hola, Marta.
Hola, hello.
Hi, nice to see you again. Marta Vera, it's one of the top radiologists I know. She will give the MRI, breast MRI talk. And well, I'm super happy to have her here today and that she's here and we can have her expertise in that. So thank you, Marta.
Thank you.
For
Thank you
everything.
very much for the invitation. Do you see the presentation? Yeah.
Yes, we're seeing it.
Okay, so just to finish with the techniques that all my colleagues have explained, I'm going to talk about breast MRI. And just a little introduction. MRI application in breast diagnosis has been developed since the 1990s until nowadays, initially with low field strength, 0.5 Teslas, with whole body coils and with slow sequences. These were really limited studies with low signal to noise ratio and were not optimal. And actually increasing field strength are being used. Yes?
No, so just one thing, can you try like put the full screen maybe?
No, I don't think I have the full screen.
No, because you should, I think you're recording one of the two screens. Yeah.
No.
No?
Which one? No. I don't know. You see everything, you mean?
Yeah, we see everything, yeah.
Okay.
Like,
I don't know how to touch this really.
yeah, because you must be sharing like just one of the screens.
No, opciones de presentación. Yeah, because I have another.
Yeah. Just if
Opciones
you
de
put,
presentación. Maybe
if
this
you put like and share the screen and then you can share just the
Now?
PowerPoint.
Now?
Yes, now yes, perfect.
Okay.
Perfect,
So,
gracias.
Now we are using increasing field strength, 1.5 or 3 Teslas. And just for you to know that specific designs for breast and biopsy dispositives can be added. So just an introduction, magnetic field is produced by passing an electric current through wire coils. Other coils are inside the machine and also placed around the part of the body that is being imaged, in this case, the breast. These coils send and receive radio waves and produce signals that are detected by the machine. So what we have to know is that in breast MRI, we need advanced imaging strategies with a high magnetic field. Normally 1.5 Teslas is enough in daily practice, but 3 Teslas increasing signal to noise ratio, especially in gradient echo pulse sequences with a better spatial resolution and better contrast in less time. We also have to consider that there is a higher inhomogeneity in interfaces between tissues and air that can condition magnetic susceptibility artifacts, and this is especially important in breast because we have a big amount of air in the center of the coil due to the lateral localization of the breast, and we have to remember this. Okay, coils, we also talked about that there have to be dedicated bilateral breast coils, preferably multi-channel. The patient has to be placed in a prone position with both breasts hanging in the coil loops, and the breasts have to be supported to reduce motion artifacts but not compressed. The signal from the body coil can be used to evaluate the correct positioning of the breast, and as well as the breast, we can analyze the axilla, the supraclavicular fossa, the chest wall, or the anterior mediastinum. So, what is the MRI technical protocol? You have to know that first of all, we do T1 weighted images, which gives us an anatomic view. It gives information about the breast composition and especially helps us in detecting fat lesions because they are hyperintense in T1 weighted images, such as fat necrosis, lymph nodes, or breast hematomas. T1 weighted images are also very useful in post-surgical breast, and we will see some examples now. And then we have T2 weighted images, which can be done with or without fat suppression. These weighted images are more sensible to lesions containing water. So typical hyperintense T2 lesions will be cysts, myxoid fibroadenomas, papillomas, or intramammary lymph nodes, as well as edema or ductal dilatations. Carcinomas are not usually hyperintense in T2 weighted images. So here we have two examples. The top image shows a patient with a T1 and a T2 weighted images. We can see a right spiculated lesion in the right breast. You can see that it's predominantly hypointense, and this was a ductal invasive carcinoma. And in the bottom image, you can see this is a T2 weighted images with fat suppression. You can see that there is a hyperintense ductal structure in the retroareolar right breast, and this corresponding to a papillomatosis. Another example you can see in the image in the left is in the top image, there is a cystic complex lesion with a nodular protrusion inside, that in the image below you can see that enhances after contrast. And you can also see that there is a non-mass enhancement in the deepest part of the lesion that corresponds to a DCIS component in the same patient. In the other image here above, in the right image, you can see a mucinous intraductal carcinoma. You can see how hyperintense it is in T2 sequences. And in the bottom right, you can see an amartoma, typical breast inside the breast lesion, where you can differentiate the fat and the glandular component. Okay, after this morphological assessment with the T1 and T2 weighted images, we have to know what is the diffusion. The diffusion sequences are very important in MRI. And these images result from studying the diffusion of the water molecules to generate contrast in MRI images. Molecular diffusion in tissues is not random. We know that it reflects interactions with many obstacles, such as macromolecules. It also gives us information about fibers, about integrity of membranes. So the pattern of water molecule diffusion gives us information about microscopic details. So typically in diffusion weighted images, we have three gradient directions to know what is the putative measure of edema, and then we calculate an apparent diffusion coefficient that indicates the diffusion process in the tissue. It indicates if it is free or if it's not free. So what is the take home that you have to remember about diffusion? Malignant lesions typically have high signal intensity in diffusion and low signal intensity in ABC. When this happens, we say that the lesion restricts, okay, that there is restriction in the lesion. Here we have an example. The first image in the left is after contrast administration. You can see that there is a round rim enhancing mass, prepectoral left breast. And in the images on the right, you can see diffusion weighted images that show high signal of the mass. And in apparent diffusion coefficient, you can see that there is a low signal of the mass. So this gives us information about high cellularity and suggests that it's a malignant lesion. And then we have the T1 dynamic contrast enhanced acquisition. Why is it called dynamic? Because it's first performed before the contrast administration and then is repeated multiple times after this administration. A T1 weighted 2D multislice or 3D spoiled gradient decoupled is obtained before the contrast and rapidly repeated for 5 to 7 minutes. You have to remember that the breast cancer has a peak enhancement within the first 2 minutes, so it's a quick enhancement, so the short data acquisition time is enough for us to study this. The choice of the image orientation is also important. For bilateral dynamic breast MRI, axial, coronal, or orientations are the most frequently used. Coronal imaging has the advantage in that it can reduce heart pulsation artifacts, but it's more susceptible to respiratory motion and also to the flow artifacts caused by the vessels that tend to travel perpendicular to the sliding coordinate direction. Although bilateral sagittal imaging is possible, but it requires about the double number of slices and it takes much more time. So we usually use an axial orientation and then with a multiplanar reconstruction analyze the imaging findings in the other planes, such as the sagittal one. The contrast that we use is gadolinium. Here is the doses. We don't use more doses because it can cause a higher uptake of contrast medium in breast tissue, and this can reduce specificity. So, sorry. Okay. We already know the protocol now. This is the MRI protocol. Now we can start performing the MRI. What we have to know before is that previous preparation is not very important. Only 4 or 6 hours fasting is needed. but we have to remember all the contraindications. And here you have some of them, such as allergy of gadolinium, pregnancy. Remember, if a pregnant woman has a breast cancer, it can happen. We will do all these protocols, but without the T1 weighted images with contrast. We can do diffusion, we can do T1, T2. Compromised renal function is also a contraindication. Kyphosis because of the position, the implantable devices, claustrophobia, there are a lot of them. And what we also have to consider, and it's very important, as my colleague talked about when talking about mammography with contrast, is the uptake of contrast in the normal breast tissue. In premenopausal women, it depends in the menstrual cycle. So when performing an MRI, it's very important to remember which is the optimal time for this premenopausal woman to perform this study. This is between the 5th and the 12th day after the start of the menstrual cycle. Obviously, in patients with breast carcinoma, it's not necessary to wait for the correct phase because it can delay decisions and treatments. During MRI, vein access for the contrast, correct positioning, as we already talked about, because of the double breast surface coil, patient lies prone, both breasts slightly immobilized but not compressed, arms relaxed above their head. Try to avoid falls and also correct positioning of the nipple. It's also important. Okay, so after performing the MRI, it's time for the radiologist to proceed to the image post-processing and interpretation. First thing that has to be in our report is the background parenchymal enhancement pattern. This has to be described, it can be described with the 4 M's, minimal, mild, moderate, and marked. Then we will talk about morphologic assessment. We will look at the lesions, we will see which is the size of the lesion, the shape, the margins, and also associated findings, such as nipple retractions, skin changes, or lymph nodes. Just to comment that when talking about size, that a lesion that is less than 5 millimeters in the breast MRI is considered as a focus and can be due to hormonal changes. Then we will look at the diffusion weighted images. We already talked about this. Malignant lesions will have higher cellularity, so they will have restricted diffusion. And then we will look at the dynamic study. First, we will do a morphologic assessment of the enhancement. This means that we will talk about mass or non-mass enhancement. When talking about mass-like enhancement, we have to describe if it's homogeneous or heterogeneous, if it's a rim enhancement, if there are dark internal septations, and enhancing internal septations, or if it's a central enhancement. So this is important for us to remember because specific patterns can give us the diagnosis by seeing how they behave in the contrast dynamic phases. For example, rim enhancement is seen with high-grade invasive ductal carcinomas, but it's also seen in cysts with inflammation or in fat necrosis. Dark internal septations can be seen with fibroadenomas, but enhancing internal septations are more often seen with malignancy. And central enhancement is seen with high-grade ductal carcinoma and vascular tumors. Here, I wanted to show you an example of a patient, BRCA patient, which has her routinary annual screening MRI study. And we can see that there is in the left breast a rim left enhancement. This patient was recalled for a second loop ultrasound. And although you can see that the lesion was hyperechoic, so it was not really suspicious, a core needle biopsy was performed. And the histologic result was a fat necrosis. So it was one of the examples I talked about with rim enhancement. Okay, more examples. Just for you to know that in the contrast, the image post-processing, in the contrast sequences, we have to do subtraction. This means that we have a contrast enhanced minus unenhanced images. This is important because enhancing lesions stand out, as you can see in the top left image. You can see a small left polylobulated lesion was a ductal invasive carcinoma. And the other example, you can see a very big mass enhancement with necrosis inside. And we can also assess about axillary lymphadenopathies and lymphadenopathies in the internal mammary chains. The other kind of morphologic enhancement we can describe is the non-mass-like enhancement. We have to talk about distribution, if it's a focal enhancement, if it's linear, like in the example here, if it's ductal, segmental, if it's regional or diffuse. And we can also talk about if it's homogeneous, heterogeneous, clumped, stipular, punctate, reticular, or dendritic, as well as symmetric or asymmetric. There are also some typical enhancement patterns that we have to know. For example, ductal and segmental distribution is more possibly seen with GCIS, as well as other entities, as you can see. And reticular or dendritic internal enhancement is seen with lymphatic involvement, such as that seen with inflammatory breast cancer. Other examples, here we have in the left image, we can see a patient, 52-year-old woman with spontaneous right breast bloody nipple discharge, and you can see there is a non-mass regional posterolateral right breast enhancement. This was a lobular invasive carcinoma. And on the right image, you can see another lesion. This is a subtraction sagittal view. You can see that here it's a linear non-mass enhancement that also had some washout areas, and we will talk about this and cyst. This was also a lobular invasive carcinoma. Okay, now after morphologic enhancement assessment, we can talk about kinetics. We use intensity time curves. You have to know that there are 3 basic curve shapes that have been described. Type 1. Type 1 is a slowly enhancing curve. Gradual, steady enhancement occurs over about 5 minutes. So it's this one you can see here in the diagram. Type 2 shows an early strong enhancement, the first 1-2 minutes, with a subsequent plateau phase. And type 3 shows an early strong enhancement, but afterwards we can see a decline in enhancement or washout. As I put here, you see that type 1 curves can be seen in approximately 6% of malignancy lesions, type 2 from 6 to 29, type 3 from 29 to 77%. So what we have to remember is that type 2 and type 3 are the most common curves that you have to remember when talking about suggestion of malignancy. MRI software can generate also color mapped images. Here we have different intensities that go from blue to red, and red reflects strong enhancement and more risk of malignancy, as you can see in this example of this lesion that also had a type 3 kinetics curve with washout. Subtraction and MIP images, which means maximum intensity projection, are also used. This gives us an angiographic effect, a 3D vision, and it's very useful to evaluate the size, especially with non-mass lesions that you don't really know where to start measuring, and also gives us information about extension and relationship with other structures, and multiplanar reconstruction. So we've already talked about the technical aspects, about the protocol, and about the imaging interpretation. Now just for you to know which are the breast MRI indications. The first one, high-risk patients. Annual MRI screening should be offered to patients with BRCA1, BRCA2, typically with mutation carriers. Also, other history, familiar history of mutations. Also, women who have had previously mantle radiotherapy before age 30, starting 8 years after their treatment. Remember these ones. They can start from 25 to 29 or from 20 years old, depending on the mutation. And don't forget women at high risk who have already been diagnosed and treated for breast cancer. This one should also be included in screening programs with MRI. Initial cancer staging is very important technique to determine all these things we talked about morphologic patterns, associated findings, diffusion, enhancement, to see if it's a multifocal lesion, multicentricity, or even if there is a contralateral carcinoma that has not been seen with other techniques. So MRI is very useful when there are discrepancies, and possible changes in therapeutic planning can result from the findings of this MRI. I just wanted to show you an example, very recent case we had in the hospital of a patient with a lobular invasive left cancer, very big cancer with retraction of the nipple. You can see it here in the image. And after doing the MRI, we could see that there was a contralateral lesion that was finally looked for by ultrasound and was also a lobular invasive carcinoma. So a corneal biopsy was performed after the MRI. Another indication is occult primary breast cancer. This is a histopathological confirmed cancer of breast type, presenting initially as a metastatic disease, mainly as an axillary lymphadenopathy with negative carcinoma breast evidence. In these cases, sometimes breast MRI can give us the information. We can see something that maybe with the other techniques was not recognized because of the small size or subtle findings. Evaluation of response to neoadjuvant chemotherapy is also a very important indication of MRI. Post-neoadjuvant chemotherapy breast MRI has to be done 2 weeks after the last cycle and within 2 weeks before surgery. And we can have different responses. We can have a complete response, as you can see in the image below. We have this left cancer with satellite lesions, and there was a complete response after the neoadjuvant chemotherapy. Or we can have partial or not complete response that can be either concentric shrinkage, as this one here. You can see that it goes shrinking gradually, or a fragmentation pattern can also be seen, as well as obviously stable or even progressive disease can be seen. Breast cancer recurrence, not ordinary MRI is done in these cases, but if there is clinical or radiological suspicion with other techniques, it is indicated. You have to be familiar with post-treatment evaluation with MRI because, for example, hematomas are hyperintensity 1, hyperintensity 2, and represent no enhancement. Seromas are hyperintensity 2, hyperintensity 2, and have normally smooth peripheral enhancement. And scars usually show no enhancement, but an early scar can enhance. So not only tumors enhance, you have to remember that there are some things post-surgical, such as necrosis, inflammation, or fibrosis, especially recent fibrosis, that can also enhance of their contrast administration. Here we have an example of a patient with a cutaneous recurrence, post-mastectomy, and breast reconstruction. Silicone implant evaluation is also an indication of MRI to evaluate the rupture of these implants, normally guided firstly by an ultrasound that gives us the suspicion of this rupture, and then we confirm it by the MRI. It's a non-contrast exam with a fluid-sensitive sequence, water suppressed here, and we can see either extracapsular rupture, where we can see silicone outside the capsule, or intracapsular, where we can see silicone external to the implant shell. Here are some examples I wanted to show you. Here we have an axial T2 image with saladoid sign. This is an intracapsular right rupture. This is a sagittal view with collapsed breast implant shell, so another intracapsular rupture. And this is an example where you can see that there is silicone outside of the capsule of the implant, so it's an extracapsular rupture. And finally, I wanted to talk about nipple discharge. This is a common symptom. Remember that if it's multi-duct or bilateral, breast imaging is not required. But if it's a single duct nipple discharge, it's considered to investigate with further information, including US and/or MRI. Normally MRI to confirm or to look for additional findings when the patient has already had the ultrasound. So here's an example of a patient who had, in the left image, you can see a tubular hyperintense structure from the retroareolar right breast. This is duct dilatation, and we can see that there is a filling defect inside, and after the contrast administration, it is enhancing. It's a solid mass with smooth margin. This corresponds to an intraductal papilloma. And just for you to see that We can also do breast MRI guided biopsy. In these cases is when we cannot do it with other techniques. So in this case, the breast is compressed between two compression plates, one of which is marked with a grid structure, as you can see in the photograph here. And using computer software, the radiologist measures the position of the lesion with respect to the grid and calculates where to place the needle and do the biopsy. Normally, as you can see, we do vacuum assisted devices are used, and the patient is positioned in the same way as with the MRI. So it's quite easy to perform first some contrast enhanced study and then proceed to the biopsy. Just for you to see that we can also do this. And that's all. Thank you very much for your attention.
Thank you very much, Marta, for your presentation of the breast MRI. Super nice. I don't know if someone has any question in the chat or anything for Marta. If not, then we have the lunch break and everything to be back at 15 hours at 3 p.m. Hello, everyone. And we're back from the lunch break. Yet we're starting on this final part of the training. Just 3 more talks to go. And but I think they're going to be quite interesting. We already talked about all the basics of the breast imaging diagnosis, and now it's time to talk more about the clinical management of this pathology. And also we're going to talk about something we've been going on around in mostly all the presentations, that is the interventional radiology. And after that, we talk about a little bit about the artificial intelligence, something that's gaining more importance every day in radiology. And well, after that, a small closure and we'll be set. So, well, I'm going to start by sharing my presentation. We're going to talk, 1 second. Second. Here we have it. We're going to talk about the multidisciplinary view of the breast cancer, and also about the multidisciplinary committee that it's like plays a key role in the breast cancer, not only the imaging, but also the management. And for that, and this is going to be different from the previous ones, because we're not going to talk so much about images, about techniques, about resources. We're going to talk more about cancer and the treatments that we have, and why is it important, this multidisciplinary view, and why I think it's key in this training. So first, I always, when I give this kind of speeches, these conferences, I always like to recommend this webpage. It's American Cancer Society, and most of the information that's going to be displayed comes from there. And it's a very, very friendly use website. It has very, very good information, super quality, and it's easy to understand. So anytime you want to search information for a presentation because you have a doubt or anything, it's amazing. Here you can see how it's displayed. I always do that because I think it's general information that's good to know. You can search for pathology. This, for example, the breast cancer, how it is organized about breast cancer, the risk, the prevention, treatment options. So it's really well explained and really, really easy to access information. It's super quality. So for me, if any day you're searching for information, you don't know how to start, or you want to, in this vast place that's internet, you don't know where to get good information from, this is a good page. And this is where I took most of the things from this like the basic things of these talks that we've been having. So, well, my personal recommendation, any cancer, it's there and it's super well explained. We first are going to talk a little bit about the cancer. I know Nacho has talked a bit about it in the first hour of the morning, but we'll share some information, also some treatments and why it's important. I mean, the multidisciplinary committee and for us radiologists, we are just as a part in all the treatment of the patient and the treatment of this pathology. So we have to work really closely with other professionals for this. So to get the best treatment for the patient, that's important to have a good communication. I think it's a little bit the prevalence, the diagnosis, the death by cancer and everything. 1 in every 12 women at some point will have this disease. So it's a quite prevalent pathology. This is data from 2020. And well, I always like to think about cancer like a very complex pathology. And when we talk about cancer, we talk about, and when we talk about the treatment and the prognosis, first, we are looking about the cell, and the second is we talk and we look at the spread of the disease. So when we talk about the cell, we talk about what receptors it has, how it can respond to different treatments, if it has, in this case, is sensible to hormones or it is not, and if it's very aggressive or it's not. And when we talk about the spread of the pathology, we talk about these 3 things. It's TNM, the tumor. T, it's like how big it is and what structures does it affect. N is for the ganglia, if it's affected or not. And we already talked about maxillary ganglia and all these affection, that how it spreads around the body through the ganglia. And then is metastatic pathology. So when it goes to other organs, other structures different from the breast. So for example, the liver, the brain, anywhere. So I am gonna talk a little bit about these 2 parts here. I know these are spread and this is all what we want to share about this. And we're gonna go really fast about the cellular subtypes that we have and about the TNM classification. That's our key information for us. So for what we can give in radiology, we have these 4 subtypes in the breast cancer. I'm going to go really fast. So if someone wants more information, just look at that web I just shared. But we have 2 subtypes called luminal, A and B, and it depends on the presence of receptors, hormonal receptors. So these are, if we can give hormonotherapy to these 2 kinds of cancer, they respond good. The Ki67, this is how the replication rate. So the higher, the more replication, so the worse prognosis, in a certain way. Then we have the type HER2, which is a receptor and that's enabled in the cell, and it's really interesting because we have we can target this receptor when we give chemotherapy, and the negative, triple negative, it has none of this, so you have to use chemotherapy in these patients. And why is this important? Well, as I said, the treatment is different for each one of these patients. So if we have a patient, when we have a cell that's, for example, luminal B, you can give this therapy here. Luminal A, you have a hormone therapy. If it has HER2, you can give HER2 inhibitors to treat this patient. And also the prognosis worsens as you go down to this classification that I just showed. So this is super important. And how we get to know this? We know it with the tisular samples. I mean, when we acquire, when we get interventional procedures and we get some part of the tumor to analyze it, so it can be analyzed. And then we talk about the TNM, it's how we classify the staging of the breast, as I just set the T for how big the tumor is. So here you can see the numbers, the cutting numbers. You can see that from T1 to T2, it's 2 centimeters. More than 2 centimeters, it's T2. 3, it's more than 5. And you can see the 4, it's also when it touches some part of the wall, some other parts of it touches the skin, touches the pectoralis muscle or anything. Then the N starts for the ganglia affected. As you can see here, how many axillary nodes or where they are. You have our prognosis. We're not gonna go through all of it, but for example, to have a 3C, it's just you have supraclavicular ganglia. So that means it's a spread over the first ganglion stages. So for example, if you have one ganglia here, let me show you, affected, is already a TN3C. So it means not only about the number, it's also about the location of them. And we already went about how ganglion spreading occurs, so we are gonna talk about this. But yes, something very important, as we said, is that when we do an ultrasound, we usually examine ganglia, axillary ganglia, and all kinds of ganglia. So we can also do something that's this. We can put some kind of radioactive or substance inside the tumor and see what ganglia does it go, what ganglia is it spread, and to know if it's affected or not. So it changes a lot the surgery depending of this. If the ganglia is affected, we have to do a lymphadenectomy and take all the ganglia off this place. And this is called sentinel ganglia. And for like when you have a metastatic involvement, I mean out of the breast, you have what we call stage 4, and you can go in the brain, the bones, the lungs, and this is systemic affection. As you can see here, this is the staging. So wait, not this, like this. You can see when it's systemic, it's for any ganglia in the 3, it's a 3C, and you can go around this way. So it's very important to have a very good staging to know what's the best treatment for our patients. And this is what radiologists do. We give a staging. So we say this tumor, it's like 4 centimeters and it has no ganglia. So then it would be T2 and 0. So then you go here and you go to stage 2A, and this is how you know how to treat the patient. And that's what we have to tell to the other doctors so they can know what to do, or they can give the patient different options. And that's why, I mean, this is how you can, I mean, a very basic strategy of treatment, you know, localized, just for example, when it's localized in surgery, and you can have no chemotherapy or no, if not needed. And when you have a metastatic, you go through chemotherapy, hair dose, or depending on the hormonal type, and surgeries just in some cases. So we have to adapt to the patient. So how big is the tumor, and also what is the cellular type and what it responds to, what's the best therapy for this patient. That's why the multidisciplinary committee, it's super important in breast pathology, in most pathologies, but breast cancer, it's the only cancer that every patient must go through a committee. And well, we'll be assessing why in this small presentation. First, because we have the importance of having good radiologists looking at this, and specialized radiologists, because we have multiple techniques. As you can see, for example, we have here what we talk about we have a mammogram, we have ultrasound. This is a positron emission tomography. You can see, which you can see here, for example, and for those of you who are not familiar with these images, here there's some finding, here another one. So you can see how spread is this tumor outside the breast. And well, and in Spain, radiologists don't do positron emission tomography. In other countries, they do. Also CT scan to assess other places of the body. For example, in here, you have the liver affection and also, well, MRI, which here's liver in here, and also MRI, which is the one with the letter B. So, well, this is a article that's, well, was published I think 2 years ago, and it takes the importance of the committee and how it's described. So this is the description of the healthcare, the multidisciplinary committee. It's different healthcare and disciplines which meet together in a certain time. I mean, for example, we have our breast committee on Mondays afternoon, and you can meet physically or anywhere, but you have to meet together and to discuss a given patient. And then every one of these specialists contributes to this, to know the treatment or the diagnostic of this patient. So the same patient is seen by, a second, by different doctors, even though this patient doesn't know. I mean, sometimes you just see one doctor, but behind the decision, there are many others who share their expertise in that. So, as you can see, and this is very, very important, it's mandatory. This was published in the UK, but also in Spain and most countries, like the multidisciplinary committee in breast cancer is mandatory for all patients. I mean, any patient, even if it's a stage 1, really luminal A, very simple case that everyone should know how to treat, has to go through this committee because of the complexity and the abundance of different treatments. For example, someone may know there's a new therapy that maybe it does not need to go to surgery. You can do local treatment, and it's no need for this patient to go to the theater room, to anesthesia, for example. Or maybe if it's stage 4, if there's any someone knows, for example, the oncologist knows there's a new research study in the hospital that's looking for patients with that kind of cancer and can involve that. Otherwise, maybe this patient would not have gotten this treatment. So it's super, super important when we think about breast cancer. We know that this patient is gonna be seen by different specialists. Doesn't matter how complex the case is, which is not the same for other tumors or pathologies, and we tend to do that, but not all the tumors or cancers are evaluated this way. So who's in by the committee? As I said, all patients with breast cancer. Everyone goes to this committee. It's very important. So as we already talked a little bit, that it's different doctors and different specialists who are in the same committee, but we are going to talk a little bit about each one of these and why is it important. So here is a small table. So first, we're going to talk about the specialist and what is the function. So for example, the gynecologist, at least in a hospital, is the one who has the first contact with the patient. For example, let's make a patient who has a nodule in the breast and says, well, I'm going to the hospital and all that. It goes to the gynecologist who has the first contact, makes the evaluation, and it can also perform the surgery if it's needed. Then you have the oncologist who once the cancer is confirmed, will have a follow-up and also can provide what's the best chemotherapy or the best systemic therapy if needed for the patient. Maybe it's localized, but it's good to have a systemic therapy just in case it doesn't spread somewhere else, or maybe it's already a systemic affection and knows which is the best drugs to give to that patient. So, for example, the gynecologist and the oncologist have to discuss when to perform the surgery, when to perform the treatment, and how and what order and everything. So then there's us, the radiologist, who help in the diagnosis of the patient. I mean, as we said, this patient comes with a nodule in the breast, comes to us, we perform a ultrasound or breast imaging anywhere. We take a sample, we do the staging with a CT scan, for example, and then after the diagnosis is confirmed and starts the therapy, we have to follow this patient and know if it's working or if it's not working. So that's a little bit, or if it's responding, or role in this committee. Then also the nuclear medicine, as we said in Spain, and all the part of the positron emission tomography in this has to be seen by the nuclear medicine and helps us to know the extension, if it's another, what the structures are involved and everything. Then radiotherapy, breast cancer has a lot of involvement of radiotherapy, local or extensive to other places. So if they need to give radiotherapy in the place after the surgery, then it needs to know, or if it needs radiotherapy for a metastatic lesion, then we can provide that. So that's another important specialist. And for me, the key one is the anatomopathologist, who gives us the molecular and pathologic diagnostic of the cancer. It's what we talked about. It can define what kind of cell it's causing this cancer, and with this we can decide which is the best treatment. Two cancers that are the same size and the same extension, if they have different molecular types or different kinds of cell, have completely different treatments. One may need systemic therapy and very aggressive chemotherapy, and the other maybe needs no chemotherapy and just some surgery, and you can go home. So this is very, very important. And what is very important is that all these professionals can interact and can talk about the patient and can understand one another. That's why I've been insisting during all day the importance of the BIRADS classification and the BIRADS standardized report, so we can all talk. And it's the same for the others. All of them talk the same language, have the same know what the other ones are saying. That's why. And why is this important? This is the classical approach to any pathology. One doctor is seeing the patient, and based on its experience and its knowledge, gives treatment to the other. And here it's a lot of people seeing the same patient. Maybe the patient never knows that. You just see the same specialist, maybe the gynecologist or the oncologist, say, hey, we made this decision, but behind that there are multiple people looking at this patient and choosing the best therapy possible for that. So well, this is a little bit for you to know what's the multidisciplinary view of the breast cancer, why is it important, and how it's treated in most cancer centers, not only in Spain, but in all the world. And well, this is a very complex pathology. That's why so many people approach it and have treated as good as they can. And well, this is a little bit the take-home message. It's a very complex pathology, has multiple approaches and treatment options. Different specialists can bring different points of view to this pathology. And the standard of care for breast cancer is that all patients need to go through a multidisciplinary committee. This means that the patient is visited by various specialists at the same time, so they can choose which is the best treatment. So, well, this is a little bit my presentation. Thank you very much for being here after the break. And well, if there's any questions you would like to address or anything, I'll be happy to answer it. Okay. Okay, perfect. So we are going to go to the next talk. It's going to be given by Dr. Moraru. She's here, and wait a second. We are going to put the presentation. It's about the interventional radiology. Here. And 1 second. Okay, now it's, well, see, I'm putting from the start, pardon, that we were revising it before. Here it is.
Good afternoon. My name is Moraru, and I will speak to you in the following presentation about image guide interventionism in breast pathology. So, as you have already seen, there are multiple imaging techniques that are useful in breast pathology, especially ultrasound, mammogram or tomosynthesis, and MRI, magnetic resonance imaging. From the point of view of the availability, ultrasound is the most accessible test, and magnetic resonance is the least accessible and most complex. So let's start with the basic. What is a breast biopsy? Breast biopsy is a medical test that involves removing a small sample of breast tissue for further examination. We have several image-guided interventional procedures that we can perform on our patients. We will see each one of them. First, we have fine needle aspiration, then core needle biopsy, vacuum-assisted biopsy, vacuum-assisted excision, and wire localization or harpoon localization, and breast tissue marker clip insertion. We will see the indication, procedure, limitation, and tips for every technique. So by ultrasound, we can use all of these techniques. With mammogram or tomosynthesis, we will usually do vacuum-assisted biopsy, wire localization, and harpoon localization, and insertion of breast tissue marker clips. And the MRI is reserved for selected patients where the lesion is only visible by MRI, as it is the most complex and least available test that we have. So we will start with fine needle aspiration. Fine needle aspiration is a medical test that involves using a thin needle to remove a small sample of tissue or fluid from a lump or a mass in the body and analyze it in the laboratory. And the indications of fine needle aspiration. So we have evacuation of palpable or symptomatic cyst, complex cyst, adenopathies, axillary or supraclavicular adenopathies, or we can also use it in hematomas or abscesses in the breast to take some sample and send it to analyze, microbiology analyze, to see which antibiotic is best for the patient. So the procedure, first of all, we have to explain the patient what the procedure consists of in the indication and possible risk and complication, and they have to read and sign the informed consent form. Informed consent form is a concept in healthcare and research that involves obtaining permission from the patient before proceeding with a medical procedure, treatment, or research study. It requires providing the adequate information about the procedure, treatment, or study to the individual in a manner that they can understand it, so they can make an informed decision about whether to proceed or not Okay, so it's an important ethical and legal principle, and it ensures that individuals have the right to make autonomous decisions about their own healthcare. So after signing the informed consent, we use an antiseptic solution, and with the help of ultrasound guided, we will punctionate the lesion or the cyst, viewing the needle in real time. We will use a thin needle, 19 or 22G. That's the needle that we use, the same that we use in when you extract blood for doing a blood analysis. And we perform a vacuum. So we will see that the sample gets in the syringe, in the needle, and a little bit in the syringe. What we obtain here are cells, okay? Here we can see how we do this, this function. We will enter and exit the lesion from different angles, and we will obtain cells inside the needle, okay? Before we take off the needle, we have to let the vacuum aspiration down. We have to terminate the vacuum, and then we can extract the needle. I had a video right here, but I think it doesn't work. So we will go on with limitations. Their limitation of the fine needle aspiration, there are high percentage of insufficient or non-diagnostic specimen and underestimation. So it doesn't distinguish in situ pathology of infiltrating carcinoma. It doesn't allow assess hormone receptors that are important for the treatment of the patient. And we do not use it in study of microcalcification because we need, in those cases, a larger sample. So the advantages and tips, it's a safe procedure in anticoagulated patients, in superficial and deep lesions. It's choice for cyst emptying, and we can see the live picture of the procedure by ultrasound. The next interventional proof that we have is core needle biopsy, that it involves removing a small sample of breast tissue for further examination using a thick and sharp needle, as you can see in these pictures. Here we can see by ultrasound hypoechoic nodule, and by ultrasound guide we will go with our needle, our core needle biopsy, through the through the lesion. And here we can see that the needle has advanced, and in this picture we can see that the needle above this has advanced too, so the sample will be here in this chamber of the needle. So the indications are palpable or non-palpable lesion visible by ultrasound, BIRADS 3, 4, 5, and 6 categories, and suspicious lymph nodes that the fine needle aspiration was negative or insufficient sample. Here we have some of the core needle biopsy needles that we use. in our practical clinic. And the procedure, it also begins with the signing of informed consent. We perform asepsis, and we installate a local anesthesia. And after the anesthesia, we perform the biopsy, ultrasound guided, with a needle minimum 14G gauges, and we obtain a minimum of 4 samples. So the first step is positioning the tip of the needle at the margin of the target lesion. The second step, we will perform a first firing, and the inner needle will go will go into the lesion. The second shot or firing, a hollow cutting cannula will fire over the previous needle, and the sample will be here. And afterwards, we will open the chamber and we will extract the sample with the needle out of the patient. Here we have more picture of the procedure, how we perform it. And here we can see the sample that we sent to the pathologist. We sent all the samples in formol for preservation, and then they analyze it on the microscope. So the limitations of the core needle biopsy, in microcalcification and distortion that have ultrasound visualization, we prefer to use another method like vacuum-assisted biopsy to obtain more samples. Thus, there is a smaller caliber of the specimen, the vacuum-assisted biopsy, and a higher rate of repeat biopsies in complex lesions. The advantage or tips, it has a high sensitivity, specificity, and a positive predictive value. It can differentiate in situ disease from infiltrating carcinoma. It allows immunohistochemical and molecular analysis of the sample. It's very useful in solid nodules, little less in microcalcification and distortion, and allows biopsy of more than one lesion in the same breast or in the both breasts, in bilateral lesions. And it's less invasive than a vacuum-assisted biopsy and has a lower cost. So the next biopsy that we have, it's vacuum-assisted biopsy. This is a system that uses a thick needle system powered with suction and a rotating cutter. So the vacuum mechanism draws the tissue into an aperture of the needle, here, as you can see here. And after the rotating cutter will go above the lesion, and it will aspirate to a collector without removing the needle from the lesion. We can take multiple samples by rotating the needle inside the lesion. So we only put the needle once in the lesion, it will stay there, and it will perform a rotating cutter from different sides of the lesion. So indication of vacuum-assisted biopsy are inconclusive results from fine needle aspiration or core needle biopsy. In histological and imaging discordance, if we see a lesion that is suspicious by imaging, but the histological result it's benign, but we think that it can be a carcinoma, we have to repeat it and do a vacuum-assisted biopsy to obtain more samples. In B3 lesions that are borderline, benign lesion but can grow or convert in another malignant lesion. Microcalcification, when we suspect ductal carcinoma in situ in patient with high risk profile, and suspicious enhancement only visible by MRI that are not visible after a second look on targeted ultrasound. So as all procedures, the patient has to sign the informed consent. We will perform asepsis, and we will instillate local anesthesia. We will perform a little incision with a scalpel, and we will use a needle that's bigger than the others, 10 or 7G, with a single incision. So the needle, it will cut and aspirate, and will rotate. It can rotate 360 degrees. As you can see in this picture, it takes samples from different sides of the lesion. So if we put our needle in the center of the lesion, it will take from all angles, okay? We will see the real-time ultrasound guidance, and once the lesion is pulled into the distal opening, it continuously cuts the sample, obtaining a higher quantity and quality of material, more than core needle biopsy. So here I have some videos that don't work, sorry. So this is the sample. This is the sample, the picture of the sample, sorry. And this is how the pathologist sees it on the microscope. The limitation of this technique are small breasts, because of the risk of the skin or pectoral muscle or nipple injury. If the lesion is very near to these structures, they might be injured. It takes a longer duration than core needle biopsy or fine needle aspiration. It's more invasive because the needle is bigger, and we have more rates of post-biopsy hematomas, and it's more expensive than a core needle biopsy. The advantages, it's more sensible and specific, and has a very good predictive, positive predictive value. We obtain larger samples, so it decreases the rate of repeat biopsies, and we see in real-time display the needle tip inside the lesion. And we always, after this precision, we will leave a marker clip in the lesion, because sometimes the lesion is so small that after the biopsy you don't see it anymore. So we will leave there a marker clip to know where was exactly located the lesion, because it's a very good form for the surgeon to know where he has to make the surgery. And another advantage of this method is allows aspiration of hematoma, because it has this aspirating mechanism, and as you can cut and aspirate the sample of the lesion, you also can aspirate an hematoma that can be formed after the biopsy inside the breast. Here you can see a picture of the difference between a 14 gauge needle, that is core needle biopsy, 10 gauge or 7 gauge samples, that is vacuum-assisted biopsy. So you can see that is more larger and better sample. And the vacuum-assisted biopsy, we can also use it by stereotactic guide. And we will use it when we see suspicious microcalcification, as in this case, and distortion. Okay, so in this case, we had microcalcification in the left breast, and after the biopsy, we perform a mammogram of the sample, and you can see here microcalcification in the sample. This is another example. Here we can see microcalcification. We perform the vacuum-assisted biopsy guided by the stereotactic guide, and in the samples on the mammogram, we can see microcalcification. And after the biopsy, we always leave a marker clip. We also use this system in MRI-guided biopsy. It's also vacuum-assisted biopsy, and we will use it in suspicious lesion, only visible on MRI when the second look or target ultrasound fails to reveal these lesions. It can be BIRADS 4, 5, 6 in multicentric or bilateral breast cancer, and in high-risk patients with any kind of mutation that increase the risk of breast cancer. So the prior steps, we review the patient's clinical history, allergy, usual medication. We review previous imaging tests, the mammogram, the ultrasound, the MRI. We explain the procedure to the patient and we solve all the doubts, and they sign the informed consent. We will take a venous access and perform skin asepsis, and we will positionate the patient in a prone position with the breast immobilized, and we will perform an resonance, magnetic resonance, with a grid that will compress the breast, and we will use a vitamin as skin marker to know where to have a reference on the skin. So this is the material that we use on a vacuum-assisted biopsy, guided by MRI. These are the sequences that we perform. Some of them are for planning. After the planning, and when we know where we will perform this biopsy, the exact point, we will perform we will put on gadolinium obturador that we can see on MRI to see if we are in the exact localization that we want, location. And afterwards, we will also leave a marker clip in the biopsy spot, and we will verify its location afterwards. So for the planning, this is the breast, okay, in the MRI, and this is the MRI where it's the patient. So the chest of the patient will be here, the nipple will be here, the head and the feet. But in the image, it's a sagittal image, so we'll have the head here, the chest and the nipple and the feet. And here you can see the vitamin that it's a reference for us to know in which quadrant are we and where will be the lesion in reference at this point. So we do the sepsis, we put the local anesthesia once we have localized the lesion, and we will insert a guide block, this piece, and we will insert a trocar with a cannula. A cannula has a cannula stop, so we perform some calculus on the worksheet grid that we see before. And here we can see that we have to put the target depth in centimeters, and we will have to add 2 centimeters more that is the space of the block. So from the skin to the target depth, maybe there are 2 centimeters. We add 2 centimeters more, so it will be 4 centimeters in total. So the cannula stop, we will put it at 4 centimeters. We will insert after the VisiLock, that it's an MRI visible obturador, and we will verify the image. What we want is that the obturador goes inside the breast, just where the lesion is. So we will see the tip of the obturador next to the lesion. If we are in the right spot, we will perform the biopsy, and afterwards we will insert a titanium marker clip. We will verify his position, and afterwards we will perform patient's care, like post-biopsy cure, manual compression of the breast with an ice pack, and we will use Steri-Strip skin closure and a pressure bandage. And finally, we will have a histopathology report after 1 or 2 weeks. The time of the procedure, it usually between 60 and 90 minutes. So here we can see the steps, the anesthesia, insertion of the cannula with the cannula stop, and this is the biopsy needle. Here we can see the samples that we obtain and how the pathologists see them on the microscope. These are some images from patient's care. You can see that it's very small incision and the Steri-Strips and the compression bandage that we perform to the patients. And there are some recommendations from interdisciplinary consensus European meetings of the sample that we need to take with every needle. So in core needle biopsy, minimum 4 samples, 3-4 samples. In vacuum-assisted biopsy with a 10G needle, more than 12, and with an 8 gauge needle, more than 6. Here we have another video, but we don't have time to see it. You can see it on YouTube. It's a video that we recorded 2 years ago, and it's explained all the procedure of MRI guided biopsy very well. So the indication, we already talked, but now we will talk about vacuum assisted excision ultrasound guided. The excision is the same. We use the same needle, but we will take off all the lesion. That's our proposal. So the indication are benign lesions like fibroadenomas, complex cysts, intraductal papillary lesions, small lesions with previous core needle biopsy positive for benign lesion, flat epithelia typias, or localized lobular neoplasias. We don't use this technique in Firodes tumor, atypical ductal hyperplasia, or extensive lobular neoplasia, because they have more risk and we want to have margins. This procedure is the same as vacuum-assisted US guided biopsy, but we will perform a complete excision of the lesion. And we will see a constant real-time display of the needle in the target lesion. The limitation, it's the patient may notice some discomfort during the procedure, and it can they can have residual hematoma. You have to have this equipment available, and you have to localize the needle under the lesion, so you can see in real time how you cut and aspire the lesion, and the lesion disappears. Limitation, it's longer than the other procedures, and it has a higher cost. Advantages is less invasive than surgical therapy. It leaves a smaller scar and is cheaper than surgery. So as you can see here, the scar of a surgery is larger than a scar of a vacuum-assisted excision ultrasound guide. And the next one is the breast tissue marker clips insertion. We have different type of tissue markers. It consists on the placement of a titanium marker through a needle in the center of a lesion, or at the site of biopsy guided by ultrasound, stereotactic or magnetic resonance imaging, like vacuum-assisted biopsy. And we will perform it in lesion prior to chemotherapy treatment, in small lesion with poor visualization after the biopsy, in the biopsy site after vacuum-assisted biopsy, on ultrasound or microcalcification, or in MRI-guided vacuum-assisted biopsy. Here you can see one of the one type of the clip markers that we have. It has this shape. This is a real marker. It goes inside a needle, as you can see. And this is how we see it on mammogram and on ultrasound. Okay, the round shape. So for the procedure, we also need the signing of informed consent, asepsia, local anesthesia, and we will insert the marker, and posterior we will do a patient's care, and afterwards we will perform an image verification by ultrasound and mammography. Here we have a mammogram with several marker clips in both breasts, different clips with different morphology. The limitation that not all markers are ultrasound visible. So these markers, if we want to take these markers of the breast, we will have to use harpoon localization of the marker. It can have loss of the hydrophilic reaction, and in hard lesion, it's difficult to leave this marker in the center of the tumor. So you can mark the margins instead. The advantage or tips, it helps to find the lesion in mammographic and ultrasound examination after or at the end of the treatment. The ultrasound visible markers, they're very useful in surgery, because our surgeons, for example, they perform ultrasound guided surgery. So they use the ultrasound to see the lesion and to take it off viewing the lesion on ultrasound. And also it helps the pathologist to study more closely the area of interest and to see if is a residual lesion adjacent to the marker after treatment. And the last of the techniques that we have, it's wire or harpoon localization, that consists in locating and marking an area of the breast of interest prior to surgical treatment by placing this kind of wire inside the breast. This wire is mammogram visible. So we will use it in microcalcification, marking the margins of the lesion to localized marker clips that are not ultrasound visible, and in some centers they also use it to mark axillary adenopathies. You can perform it on mammogram or ultrasound guided, and it has to be the same day prior to surgery. Here we can see an example. We wanted to mark this marker clip, and we put a harpoon wire to localize it. This is another example. So the patient it's in a sitting position, and we perform a mammogram, and we detect the area to be punctured, and we will ask the patient to be very steady, and we will have the breast held and compressed with the mammogram. We will clean the area, we will put anesthesia, and afterwards we will put the harpoon in the location that we want, and we will see if with control mammogram if the harpoon is correct and it's fixed, so it doesn't now move. Here we can see a mammogram before the surgery that we put this harpoon to localize a clip marker, and this is the piece of the surgery when we can see here a tumor and here the clip with the wire that localized the clip. This is another case of a marker clip that we mark with an harpoon. You can see here the marker clip and our harpoon that we put a mammogram guided. So limitation are small breast or and we can have minimal displacement of the harpoon with the decompression of the breast. The advantages, we can use larger wires in larger breast. It's a surgical map for surgeons, so it has to be there has to be a good communication between radiologist and surgeon, and we have to always choose the lower distance from the skin to the lesion. And that's all. Thank you very much. If you have any questions, you can find me at this email, and that's all. Thank you.
As just closing, I have a closing slices, but one second. Okay, so well, I think we've been quite on time, a little bit early even, and well, this comes to an end. We've covered more or less all the topics that we talking about in the morning. I think after hearing all this, you must have a clear image of all the clinics that we have, how those breast pathology looks like, and how we proceed in the diagnostic imaging of the breast pathology and here in our hospital. I really want to thank you all for being there and hearing all this, and also want to thank all the staff that's been working hard for the presentations, all the doctors that have come and those who have sent their presentations. And I mean, it's an amazing job, and they are like Dr. Iroa, now they're working in the clinic at this moment, so they took time for that. That's amazing, and I really thank them from the bottom of my heart. And well, it's been the mark of the QUSTom project, and I think that we also talked about this in the beginning of the training and of the course of the presentation, that we are trying to develop this new imaging technique, which I think can make a big revolution for all the patients that we see and all the women that are included in the breast screening program and all the diagnosis. I think there's a chat thing. Yeah, thank you. Okay, so well, after this, I think this is we are in this is the present and the future. I wish that we can, all this serves us to dream in a better future and a better world where we can have better diagnosis of the breast cancer and the breast imaging and provide better care for our patients and our clinic practice every day. So after that, thank you all for attending, and thanks for your implication and to make it this far. It's been a pleasure to be your host in this training today, and well, hope to see you around. And if there's any question or anything, you can still have it in the chat, or you have all my emails being everywhere here without the capital letter. And well, I think we are perfect for the time. And if there's nothing else, I will leave here the training. I just say thanks to all of you and to see you around. Thank you very much.